and move on to the next session. And for that, I invite the chairperson from next session, Dr. P.G. Sundraman from Chennai and Dr. Isisa Sachdev from Mumbai. Good afternoon, everybody. First of all, I must thank the Diabetes India, the organizing committee, for giving this opportunity to be here for you. In fact, clinical debates is to enrich our knowledge, and these debates will definitely pave way for better understanding and also to evolve the treatment of these conditions. So the first topic will be introduced by Dr. Rishika.
So technology is constantly evolving. Now, what is in practice today might not be tomorrow. So let's have a very interesting discussion between Dr. Arun and Dr. Jimit sir. Dr. Arun Raghavan, he's a consultant diabetologist at Dr. A.R. Chandran's Diabetes Hospital. He's received multiple awards for his contribution, and especially his contribution during the COVID times. Dr. Jimit is fellowship in endocrinology, diabetes and metabolism, and he's practicing at Surat. We welcome you, sir.
I think I'll just highlight how we proceed this. Each speaker will be having 10 minutes of his talk and about 1 to 2 minutes of rebuttal. We can have 2 responses for the talk and final conclusion after that. So total 25 minutes. So I think Dr. Arun will start. After the technical clauses.
We can talk about technology. Something is not uploading.
So can we go for the talk against it?
No, second debate for whole session.
Okay, we go for second debate.
Yeah. No, how can you do it reverse? Yeah. Reverse you can
education of the speaker. So how he reflects and how he takes on.
We have to go to second.
What's happening? 2 minutes?
No, no, bro. Done. Done, no?
It's done. It's done. It's done. Okay, so the problem is solved.
It's okay? Okay.
A pleasure on you, sir. Thank you, chairpersons. Thank you for the introduction to the topic. And at the outset, I would also like to thank the organizers of Diabetes India of giving me this opportunity. So, the topic that's been assigned to me is whether do we need blood glucose monitoring in an era where we have the flash glucose monitoring, CGMs have flashed into the scene, and indeed they have transformed diabetes care. We were also discussing about certain platforms, apps that are heavily hinging on this technology, and there are some million-dollar startups which only rely on CGMS. So we do know that they have transformed diabetes care. But is it fair to say that they can completely replace blood glucose monitoring? Perhaps not. So on that note, I think all of us are aware that blood glucose monitors have been used in all major glucose lowering trials. All the glucose lowering trials have used as a core component of effective management of diabetes. So on that note, let me take you back in memory lane. Glucometers have been around for over half a century. The first glucometer is shown in this first image, which is AMS reflectance glucometer, which was developed by Anton H. Clemens. Interestingly, the first reported patient, the small story to it, who used it was Richard Bernstein. This gentleman was so fascinated with this glucometer. He was a type 1 diabetic patient. With a lot of trial and error, he started adjusting his insulin dose, and then he became accomplished in managing his own disease. And then, to his dismay, the medical fraternity did not listen to him. He said glucose meter, blood glucose meter is extremely useful in managing my disease. Nobody listened to him, which in fact prompted him to pursue a medical degree, and finally he published a lot of papers, subsequent to which AD also accepted him as a standard of care. And this is the gentleman himself. He's about 87 years old, and this itself is a testament, validation to the fact that glucometer was indeed a life changer for him. So this is Richard K. Bernstein. And he still, suggested he has written a lot of books and papers on blood glucose meter. So who needs a glucose monitor? Pretty much all patients with diabetes. However, type 1 diabetic patients, all of us, if I see a patient with type 1 diabetes, the first thing I tell the patient is that you have to get a glucometer, because it is a very important critical part of any journey, any patient's journey with type 1 diabetes. However much data that we could have, the glucose meter is only going to help the patient to manage disease more effectively, and sometimes they learn the craft even better. They learn to monitor the blood glucose depending upon their food intake, exercise, so on and so forth. And obviously this gives us way more variability, intra-variability in patients with type 1 diabetes. Type 2 diabetic patients, the data suggests that patients with secretagogues, insulin, there is a lot of data to show improvement in outcomes. However, in patients with non-hypoproducing agents, there is not much of data, but still we know for a fact that it could still be useful in patients who are even on incretin-based therapies and metformin and so on and so forth. However, in patients, as I said, who are on insulin or on secretagogues with the hypoproducing agents like sulfonylureas, they should have a glucometer. And of course, in patients with pregnancy, stringent targets are always enforced, and again, glucometers are used. Now, coming to the main fundamental difference between a blood glucometer and a CGMS. Now, interstitial fluid is where the sensors are, right? Because the monofilament is about 5 millimeter, and the filament survives longer in the interstitial fluid than in the blood. So that's why we have a little different technology here, and all of us should be aware that the truest number of glucose levels is in the blood. The blood glucose meter reading from a blood sample gives us the most accurate glucose reading. However, glucose over time diffuses out of the capillaries into the interstitial fluid, where a CGMS then can read it. So there is always a delay, at least about a 15 to 20 minute lag. So it is not always accurate. It gives us the estimation, but it is not accurate. And BGM, CGM numbers are more likely to be different in hour or two after eating when blood sugar is quickly rising or falling. So particularly in a patient who's exercising or frequently eating, there you would have more fluctuations between BGM and CGM, particularly when there's a lag. And coming to the glucometers, the FDA as well as the ISO gives us about 20% variation, but today's glucometers are much more accurate. The percentage of variation is very, very less, up to even about 5%. There are glucometers which have only about 5% variation in today's era. So where we need increased accuracy is patients who have hyperglycemia unawareness, patients who have, again, we've seen through this data, patients who are pregnant, patients with the history of severe hyperglycemia, and more often these patients would need more accurate glucometers. So some information on what impacts blood glucose meter accuracy. Manufacturing defects as well as test strip lot-to-lot variations can also impact blood glucose meter accuracy. And the other factors which could also influence test results would be competing blood substrates such as maltose, vitamin C, uric acid, galactose, acetaminophen, ascorbic acid, as well as environmental issues such as cold temperature, high altitude, other contaminants in the skin from food sources and lotions. All these could actually impact the test results. So this is another important information that although we have devices which are approved, there is a study to show that more than 40% of meters actually failed to meet the standard at which they had first gotten approval. So this is something that we have to be aware of when we use glucometers. Yearly once calibration is something that perhaps is required. I'm going to show you some data to enforce how glucometers have played a role, blood glucose monitoring have played a role. Frequency of SMPG correlates with HbA1c and acute complications in children and adolescents with type 1 diabetes. So in this study, more frequent SMPG in fact improved outcomes in terms of HbA1c reduction in patients with type 1 diabetes. Similarly, structured self-monitoring of blood glucose also significantly reduced A1C levels in poorly controlled non-insulin type 2 diabetic patients. And another data to show a stronger association between frequency of self-monitoring of blood glucose and A1C in type 1 diabetic patients. So there's multiple data, and there is also this suggesting that CGMS cannot be used as a replacement of glucose meters because it does not satisfy the conventional performance goal set down for in vitro glucose measurements. So this shows you the accuracy between the blood glucose monitoring and CGMS. Now this shows, compared to the plasma sample, pretty much on par. The blood glucose meter readings as well as the plasma samples are pretty much neck to neck. Whereas if you look at the graph, the comparison between CGMS as well as the plasma glucose, you can see it is quite varied. So that's the difference. That's how accurate blood glucose meter is compared to the CGMS. So interstitial fluid glucose is just not a shifted in time, but it just gives you a distorted mirror of blood glucose. So finally, let's look at some benefits and comparisons of SMPG, CGM, and FGM. SMPG is indeed time-tested, very, very cheap, very accurate, and one of the biggest challenges of CGMS is the retrospective device perhaps is cheaper, but the real-time CGMS is extremely, extremely expensive. Not many people, at least at this point in time, can afford it. And the sensor life is also quite short. We do have some in the pipeline, such as Eversense, which could give us data for even 6 months, which can be implanted. So that is going to give you about 6 months data. But at this point in time, we only have technology where it gives you data for only a few weeks, and it's extremely, extremely, extremely expensive. And that is one of the major limiting factors for CGMS use. And this is some data that we've already seen. And the US FDA has also recommended that if CGMS is inaccurate, including whenever there is a suspicion, we have to rely on glucometer. So glucometer cannot be at this point in time replaced by CGMS. And to finally conclude, I think we have the resources and technology today with us, and we have to use all available technologies and resources to improve patient outcomes. And at this point in time, I think both blood glucose meter and CGMS can be complementary to each other, and that's how we'll have to go. And to conclude, I think, yes, indeed, we still need blood glucose meter in the era of CGMS. Thank you.
Thank you. Dr. Jimit, sir.
Yeah, thank you, chairpersons, for the kind introduction, and thank you all the organizers of this wonderful conference for inviting me to speak here. Let me just load the stop working. Yes.
The computer is the fighting mode.
Yes. So, I'll be discussing no to the answer. Do we need blood glucose monitoring in the era of CGM or flash glucose monitoring? My answer is no. Yeah. So, Dr. Arun has already mentioned some of the pitfalls, but he clearly said that both these technologies, they complement each other. So I also agree in the initial part of my talk only that they both agree. They complement each other. So I'll be discussing very simply and very fast advantages over BGM, okay, in glucose monitoring itself, and what are the additional advantages over blood glucose monitoring in our glycemic management. So definitely the first disadvantage is what we all have with BGM is it's really painful. Okay, whatever fine needle you will take, it is going to be painful. And remember, those type 1 diabetes children, those pregnant women, they have to prick many times a day, and that will be a very troublesome for that lady or for that mother to or that child himself, and a psychological trauma also. On the other hand, we all know CGMS virtually painless initial administration. Later on, it is painless virtually at all. Also, it can lead to non-compliance whenever pain is there. Okay, remember all our children are told कि बच्चा ठीक से रहो नहीं तो आपको सुई दे देंगे, इंजेक्शन मार देंगे. So everyone is afraid of pricks from their childhood. So whenever there is a pain and pricks, it leads to non-compliance due to this psychological barrier. And this non-compliance can eventually deteriorate your glycemic control also. And very importantly, it can lead to hyper or hypoglycemia also. Also, BGM or the SMBG is still a very difficult task to perform, especially if you take the elderly, if you take the patients with neuropathy or retinopathy. It is very difficult task. You can see there are a number of steps involved in a single SMBG, and it's very difficult. On the other hand, if you take CGMS or flash glucose monitoring, it's very easy, just touch with your device, or even with the newer advancements. Okay, you can directly have your blood glucose level flashing on your mobile and with the hypo alerts also. So it's very easy nowadays. Also, it's not always accurate. The accuracy standard also, Dr. Anu himself mentioned what are the conditions which affects the accuracy of glucose monitoring. And very importantly, he said about the accuracies, but our Indian scenario is totally different. We have so many companies with, I would say, not substandard but less accurate glucometers, and the variability is huge with all glucometers that are not from the reputed brands or the US FDA approved brands. And the costlier one, which are more accurate, they are not affordable to each and every individuals. And there are also quality of strips and amount of blood put on strip, the time taken, it depends very hugely. Also, very rare nowadays with the advent of the disposable items, but it can cause infections. Very importantly, sharing of glucometers and sharing of these needles can lead to cross infections also. Also, very important aspect of diabetes management is data record and how you convey this data to your healthcare providers. And it becomes very appropriate to use the highly, we have multiple apps we are discussing since morning, apps and data and all those things. And CGMS has digital records and extremely helpful for us clinicians. And also very important thing, I have seen few patients, you can also correlate some of your patients who are willfully entering wrong data also. So this can be avoided. Cost, Dr. Arun has already mentioned, but even a single SMBG from a reputed brand will cost you 20 rupees just for the strip. Okay, the needles and all other things are separately, but don't let money run your life. Okay, let money help you run your life better. Very importantly, glycemic management beyond just glucose management. What are the advantages? So yes, we all know if you just take 4 readings, you can see here, definitely you will find there is just one reading above the target. But if you put on CGMS or flash, you will see the complete picture. Okay. Also, we have seen with the A1C of 7 may not represent the total values. You can see on the right side the patient is in 100% time in range, but on left side you can see there are hypos also, hypers also, and there are only 40% time in range. Trends, very important. If you see this boat with no context, it's like blood glucose monitoring. You don't know where it is going. But if you put a CGMS, you will see that the boat is going towards the danger. So there is a trend, and if you use this trend with a proper guidance and your clinician, you can also divert that boat towards safety and avoid the danger of hypo. This is again a very important when you see the complete picture with CGMS. And whenever you see there is the blood glucose monitoring is always raising down, another is demystifying. If you see a patient is 160 with the BGM, after sometimes they will have one question also, is my blood glucose going up or down? But remember, with CGMS, you get the trend that your blood glucose level is going down or low. Again, efficacy, hypoglycemia, glycemic variability, time range. So we are moving from glycemic triad to glycemic hexad. And very important thing is we want to address the glycemic variability because it can lead to oxidative stress and increase the risk of complications. And nowadays, we have newer metrics for measuring glycemic variability, that is time in range, that has been discussed a long time from nowadays. And it seems impossible for a single SMBG or BGM to precisely detect either glycemic variability or time in range. So do we have data for time in range? Yes. Same as what the UKPDS and DCCT trials they have mentioned for HbA1c control and the long-term complications. We have data with TIR also. For each 10% reduction in the time in range, you can see the progression of the retinopathy increases by 64%. Microalbuminuria progression increased by 64%. And any type of pain or moderate pain of neuropathy also increases. And each 10% increase in time in range, okay, also associated with 6.4% lower risk of carotid media intima thickness. Also, the evidences are also gathering now. Few of these slides Dr. Arun showed, they were from 2003, okay, that showed the accuracy of blood glucose monitoring with the CGMS, but those slides were 20 years old. But now we have multiple evidences we are gathering for CGMS. The impact study shows that if your patient uses CGMS, even type 1 diabetes patient, okay, who are well controlled on SMBG, if you put them on flash glucose monitoring, it increases the time in range. Okay, these are the patients who are already well controlled on multiple SMBG and type 1 diabetes. There, if you put them, you still get further increase in the time in range. Also, it also reduces the hypoglycemia rates who are already controlled type 1 diabetes on SMBG. Also, replace study shows for type 2 diabetes also, it reduces hypoglycemia. Similarly, it also showed reduced hospitalization for type 2 diabetes. Similarly, Russell et al. Also showed reduced in the ketoacidosis rates also for type 1 diabetes. Flash study also showed reduced hospitalization and worse absenteeism in type 1 diabetes and also type 2 diabetes if you use flash glucose monitoring. Similarly, it also improves quality of life. So in last, I would like to tell my good friend Dr. Arun about this question. If blood glucose monitoring will be able to answer all these questions, what time of the day are in ranges blood glucose, what are highs and lows, should medication dose be just be adjusted at exact what time it should be adjusted, how frequently I am suffering from hypoglycemia in a single day. We have seen tremendous number of cases of undetected hypoglycemia with CGMS. For how long I was in hypoglycemia, how is my daily glucose pattern, how my daily routine is affecting my blood glucose along the day, like exercise, how, what's going on with food, sleep, exercise, stress decisions, what is working and what is not working in my diabetes management. I just made a change, but did it make a difference? We don't know until we put CGMS. So both CGMS and A1C, both SNBG and A1C doesn't reveal any enough data to answer these questions. So my answer is no, and I thank you everyone for listening.
Can I have Dr. Arun put in the please?
Yeah.
2 minutes.
Sure. Yeah. Not just like.
I think maybe both of us agree with each other here. So, of course, CGMS gives you the insights, deeper insights, train all of it. But the only argument against it is, can we have CGMS for all patients in India? It has not been approved in the US as part of insurance. Even in a developed economy, patients are not able to afford it all the time. So, particularly in Indian out-of-pocket population, I think how many of us who have subscribed CGMS for all our patients with diabetes? You wouldn't have it. I think it might have been possibly 2 to 3% of our patients is possibly on CGMS. So the real challenge is the cost. And the sense of wear time is also shortened. So these are the real 2 challenges against CGMS. And that's why I feel that it is complementary. We need blood glucose monitors as well. And possibly use CGMS in patients where patients are glycemic variability, hypoglycemic unawareness, where we may have felt, okay, patients' experience is okay, but patients gives us some other history of high and low sugars. These are, the ideal patients whom we have to use this resource and technology. Thank you.
Thank you.
Just to answer the cost part, so we have all seen the evolution of technology. Okay, so phone Dr. Arun is using, that was costing, if you say 20, 30 years back, we were not assuming that he will be using this phone, because the initial mobile phone, like the glucometer you showed, was costing lakhs of rupees just for do a single 2G call. Okay. But now we have technology, even the chai wala, pani puri wala is also using smartphone. It has 4G inside and it is using it for YouTube. So technology is evolving. We have seen the dramatic reduction in the cost of CGMS. We are not putting CGMS 5-10 years back, but it is now very much affordable. And I'm sure in next decade, it will definitely replace the BGMS.
Any quick response to responsible knowledge, please?
Question. A patient on CGMS, any patient, do you think that sometimes psychologically they start getting paranoid? Okay, every 5 minutes they'll check, every 2 minutes, okay, I ate this, I ate that. अच्छा डॉक्टर ने 2 नहीं 3 रोटी खाऊं. Something like that. Have you seen that in the clinical practice, and how do you deal with that?
So that can be an issue with each kind of treatment. But what you are saying, we can look it in the other way, like educating our patient in this respect. That you tell your patient, you check it, and once you get to know that what is increasing your blood sugar level, what is reducing your blood sugar level, next day you can have these resources or have this information to improve your blood glucose level the next day. So that's how you educate your patient and counsel your patient. But as you said, some parallel patients definitely will have this issue.
Yes, sir.
Yes.
Since I am working in a hospital setup, unfortunately CGM does not come into play in hospital patients. Especially in critical care,
Correct.
I think blood glucose monitor is the only thing that we can manage. So that part also should CGM does not have any play. Number 2 is that patients with CGM, they cannot do any kind of scan like MRI when they are on. So we do have some issues which
Actually, I didn't find any sparks of fire. That both were complementing each other. The CGMS is a quite useful machine, and it is cheaper and it is done readily available, and it is easily understandable by the patient, and he can do of himself and interpret himself, and accordingly he can manage to a very great extent. But CGMS has its own advantage of going into the profile of the blood sugar, which is inclusive of the glycemic variability, time in range, and what happens in the episodes during the sleep, especially hypoglycemic events. So that is not being taken care by the usual blood glucose monitoring. And also needing assistance, where some company or pharma people or somebody must come inside to understand and give you the profile. So that is the main advantage of the CGMS. But each are complementary. As I said, it depends upon patient. It's a patient centric. Which patient you're dealing, whether type 1 or type 2, or whether the patient needs a particular area where he goes into liquid hyperglycemia or hyperglycemia. Especially if your HbA1c is not very well controlled and the blood sugars are very varying and recurrent hypoglycemic episodes, definitely this patient needs CGMS. But in all other cases, the usual blood glucose monitoring, I think, is easily available and it is done easily by the patient. So both of the machines are complementary to each other, and everything is patient-centric and depends upon the situation. Thank you. We will go to the next session where do Indian dyslipidemia needs special attention? In fact, dyslipidemia is a big topic. It has nothing to do with diabetes. It can occur as a single event or as associated with diabetes, and is very well about 40% of the global burden of CVD risk occurs in India, and the Indians are more of atherogenic potential, and something happens, the variation of the lipid profile also. So, does we need this Indian attention of the dyslipidemia is going to be taught by Dr. Rakesh Kapoor.
Dr. Raka, Shiva.
Sorry, Raka Kapoor, Hindi poet. I'm sorry, you are a Hindi poet. Director, Lifetime Madhuni Diabetes Hospital, Sarah Madhuni Diabetes Welfare Society, and he got a lot of
प्रेजेंटेशन में ये
papers
प्रेजेंटेशन में
and awards.
ये स्लाइड आ रहा है ना, ये तो नहीं आना चाहिए ना।
Achievements.
मैं किया था सर,
And
फिर
he
किया
got on
एक मिनट।
Dr. Raka Kapoor.
Myself, Dr. Raka Shivhari. Actually, it's my father's fault that he has not given me the Hindi meaning. Actually, SHIVHARE is real pronunciation, but because my father was in Air Force, he has copied Kapil Dev, because Kapil Dev is written as DEO and DEB also. So he has given him, and the more time I have to explain myself that it's not Shivo, it's Shivhari. So Raka is a time when Chandra gets cool, is a nakshatra. So that's the way.
Display. See the three dots. Right click on it. The presenter. What happened? They're trying to get the full screen actually. It's coming in the presenter. नॉर्मल पीपीटी खोल के फुल स्क्रीन कंप्यूटर में फुल स्क्रीन करो।
जी भाई आओ ना, तो मेरा नहीं है
आपके वो फेस हटा ना, हटा।
So at the outset, I am thankful to all audience and Dr. Vansi sir and Ishita and sir for inviting us in this great debate. And I think I am very thankful to Dr. Vansi for releasing me to have given such topic, which I feel that it's setting more of for me, and it's a real battle for Dr. Ajgaonkar sir. because so there is no doubt in this topic that Indian dyslipidemia should be taken as a different aspect. Dyslipidemia in Indian, is it different? Why it's not changing?
तो click on the slide. Slide पर click कराओ ना.
वो साइड का बटन होता ना सर.
Changing here but not there. So dyslipidemia in Indian, is it different? Yeah, definitely. There is no doubt. Because every Indian is different. The new
Next
World
debate.
APA-ACHA
Arvind.
in
You have
2019 ACHA
presentation in
report
front.
say that high cholesterol
So
people is
they
not
will directly
one
play
size fits
this
all,
there.
and guidance strongly establishes that importance of personalized care is the more personalized care, and more personalized care. Every body, every human being has to be taken as a different model from God. So multiple target for CV reduction. It can be LDL, SDL, DG, ApoB, lipoprotein A. But it's time-honored success that LDL target is beyond doubt for CV risk reduction. And why I'm talking about LDL? Because being Indian, we are the most sufferers. Dyslipidemia Indians, is it lifestyles or genes or both? Dr. Yajnik was here. Fortunately, we have a hard discussion throughout the morning walk also, and we are going to quote his statement of YY paradox. And diet is difficult. Dyslipidemia profile seen in vegetarians is totally different. Indian diet is rich in carbs, low in omega-3, OFAs, and that's why we have high degree of exacerbation of hypertriglyceridemia. And we all know that Asian Indians are physically inactive. We, from any part of Southeast Asia, we are physically less active, maybe due to fast economic development in recent years and modernization. Genetic factors, we have abnormal variant of ApoC3, ApoE3 genes coming in India, and Indians have more abdominal adiposity. And there is different hypotheses of thrifty genes which other needs to blame for these kind of presentations of dyslipidemia. So how and why Indians are different? Because we are more prone for CSD at younger age, more likely to have anterior location of infarction in territory of left main, multivessel and distal coronary artery disease. Similarly, having lower prevalence of traditional risk factors than with other populations. Prevalence of diabetes is uniformly higher in all of the part of our country. And why? We have enough explanations. We have given the concept of thin fat phenotype to world. LDL particle size tends to be smaller in us. Serum triglyceride highest in urban Asian Indians residing in India, or whether they are migrant Asian Indians. Wherever they go, they keep their triglyceride level high. Average serum triglyceride level of rural-based Asian Indians is also higher than Caucasians. Lower SDL, LDL with lower SDL levels with higher concentration of small, less protective SDL particles are quite often seen in us. So impaired reverse cholesterol transport have been also proposed hypothesis. So how and why Indians are different? Story continues that altered adipokines may explain why lean non-diabetic Asian Indians have decreased insulin sensitivity compared with others. And this is the same Yudkin-Yachkin paradox, where we have high body fat in spite of having
lower BMI. So diabetics and dyslipidemia, this suggests that there are 55 million of patients of diabetic patients in India, and prevalence of diabetes in males is less than what we find dyslipidemia in females. Our females are more sufferers. This is the study from R.M. Parikh et al. From Metabolic Clinic Research and review from 2010. In India, almost 9 of 10 diabetics have dyslipidemia because we have abnormally large enlarged adipocyte. If you compare with a South Asian adipocyte with a white Caucasian adipocyte, then you can very well find that large subcutaneous abdominal adiposity size predicts insulin resistance more and type 2 diabetes independent of obesity. This is how we compare our Indian belly with others. There is a generalized obesity in common in Western population, but we are more fat-bellied than others. So abdominal visceral obesity associated with higher risk of type 2 diabetes and CST generally compared with the Caucasians. So average level of serum triglyceride, if you see Caucasians, Asian Indian migrants, Asian Indian urbans, Asian Indian rurals, slum areas also, we can have high number of triglycerides in Asian Indians, all types of Asian Indians. Average level of HDL, if you compare, then we have bad data as compared to them, other people. Pattern of dyslipidemia in India, we have mixed, combined, isolated single parameters. And if you talk about ratio, then most common pattern among males is isolated single parameter dyslipidemia with low HDL, and among female, we have slighter higher occurrence of mixed dyslipidemia. So Indians are in many ways different, heterogeneous population where atherogenic dyslipidemia prevails, and that's why treatment schedule we individualize. By listing all these, I can see my opponent face who is just searching and planning for this Vanprasth ashram. Is it possible in modern times? Because there is no point to take it counter. But I salute that he has taken such a hard battle and he will try to prove himself. ACC/AHA 2018 guideline for cholesterol management have shown that LDL-C threshold values are very important, not given important to SDL-C, triglyceride, and non-SDL-C. Basic principles and intervention, I don't want to go what are the therapy, because my topic is not of therapy, my topic is because that Indian dyslipidemia. So basic principles of interventions remain same, taking omega-3 fatty acids, statins remain effective in reducing LDL cholesterol, and that's why we have proponent of statins and fibrates. Fibrates affect better in Indian subset because patients with high triglyceride levels, when they do not respond normally, then we can have to add. So fibrates turn to be a good fighter in this Indian dyslipidemia setups, and how long we need to go, this we need to calculate from a benefit risk score, and we have enough study data protocols in the backup which can show that lower is the better, because we are when we get accustomed to life from our mother's womb, we are having a very low LDL level, and due to our lifestyle and habits, it grows. We take birth with 20 to 30 milligram of LDL, but when we grow more, we are getting more and more LDL because of our diet habits and epigenetic factors. So Indian dyslipidemia turns to be a crucial indicator for all kind of treatment, and that's why we are getting more cardiac morbidities. And this has been proven undoubtedly in so many studies that if you go on controlling and reduction in LDL concentration with statins, then you are going to get reduced evidence of clinical morbidity of cardiac consequences. So evidence from these LDL lowering therapies have shown enough that we are born with LDL of 20 to 30, but for secondary prevention, lowering of LDL CO2 at any level can be safe. When we are talking about LDL, then we are talking about Indian dyslipidemia, and there we have Indian data which have shown in guidelines, our own guidelines in 2016 has shown with so many of us here in this conference, are the part of this 2016 Lipid Association of India expert consensus, and they have found that risk category with LDL of less than 50 should be target with very high risk. And with high risk, we have to further categorize and strengthen our treatment. If your patient does not respond to non-pharmacological intervention for last 3 months, then we need to categorize more. And this Lipid Association of India in latest 2020 guidelines have added extreme risk category also, where they have opted for less than 50 as a target and less than 30 as a target. So with this listing of these all, my opponent has now planned for pilgrimage, and Mr. Opponent, this is your travel plan. So here comes the conclusion, and I'll take pardon that I'll be in rebuttal, I'll be placing 3 more slides. The slides is here only. So conclusion that Indian population has dietary, physical, and genetic diversity, which leads to different dyslipidemia from Western counterpart. Indians in having lower total cholesterol, lower HDL cholesterol, and greater triglyceride level. The low HDL cholesterol and hypertriglyceridemia are metabolically interlinked, and their combination has been termed as atherogenic dyslipidemia, and that's the cause of metabolic mayhem, of cardiac morbidity in our country, and that's why our Indian dyslipidemia should be taken in account with any kind of clinic, whoever is practicing in India should be bothered and should be taking care of heart of a patient, because diabetics don't die with sugar. Diabetics die with either with the cardiac morbidity or due to renal complications. So statin along with fibrates can be effective choice because of that kind of dyslipidemia. I'll complete my talk. For the first part of talk, my talk is completed. I'll say to chairpersons.
Also with some cross-down patients, I call upon Dr. James Kumar, who is the professor of the department of General Medicine, Medical College Hospital in Nara. He is undergone training in endocrinology at Best Presbyterian Hospital in New York, USA, and he has got number of international national awards. And he is the member of various societies. I call upon Dr. James Kumar.
I think you need to call your IT guy. Call Arctic and call the IT guy. I wanted one laptop also to be replaced, not this one.
Yes.
Yes.
Now it's changing or not? Change menu होता है
Good afternoon. Thank you, chairpersons, for the kind word of introduction. I really like your talk, Dr. Akash. I think we are meeting for the first time, but I think we have a lot of likings with each other in your thought process. I think ultimately, I think you will conclude that
You are surrendering.
that you will say, I mean, you agree with whatever. Just give me 10 minutes. I think चंद मिनटों का बात है. We'll soon agree. So the question is that why I think the brief is very clear. I mean, do Indian disability need special attention? The question is that do they require special attention? Probably not. And reason is that I am going to, this is the synopsis, I am going to give you a case. This is a kind of a patient, a person who walks into an office, a 46-year-old man, comes for a master checkup. He has no major symptoms except for occasional breathlessness. He is not diabetic, he appears overweight, he has a BMI of 28, ECG is normal, and his lab investigations here reveal total cholesterol on the higher side, LDL and triglyceride, and a low HDL. Now the question is, will our approach towards this patient differ if this patient's nationality has to be a non-Indian, if he has a different passport? The question is that we all know that dyslipidemia, forget about the primary causes which are totally, they are rare, genetic, but look at the secondary causes is mostly driven by obesity, type 2 diabetes, and probably some medications and physical inactivity. The reason why that Indians are not different, we are the same because we have not changed from our Caucasian counterparts, because our change in the epidemiology is because of urbanization, and because of that, and because of our access to the medical treatment management has improved. It tells you that our improved the expectancy of life, and hence because of the Baghdad ka Zindagi has increased the stress, and ultimately the changing of the pattern. Now is the time where we have more takeaways than what is being cooked at home. So this led to the increase in number of CVD as well as earlier onset of diabetes. And let's look at the lipid profiles of Indian versus the others. You can see the South Asians, including Indians, generally have the similar or lower LDL cholesterol when compared with other race, even though there could be some differences in the different races within the Asian population. Compared with the other ethnic groups, South Asians tend to have a lower HDL and the ApoA. But however, if you look at the risk stratification, there isn't much of a difference. The data on triglyceride, however, is varied, and most studies does not suggest any major differences between the Indians and the rest of the world. And I have the point to prove is that if you're looking between the Americans and Indians in this particular study, which I'm quoting, you could see that the triglyceride and the LDL, when you compare between the Indians and the Americans, are the same with a significant p-value. And if you're looking at the relative risk of acute myocardial infarction between the different ethnic groups, when you compare the South Asians with an overall, that is global, you don't see any great difference between the total cholesterol that is seen in South Asians versus with that you see in an overall 1.23 versus 1.16, even though you can see that the HDL cholesterol is much is 0.92, which is a bit higher than the overall the global population. So you can see that even though there is a subtle difference, there is nothing gross to talk about the changes in the LDL as well as the non-HDL, the total cholesterol as well as the non-HDL cholesterol, which are probably more atherogenic. And if you're looking at the dietary recommendations, if you look at the global recommendation, it's the same. It's almost similar. And if there has been a difference, there should have definitely be a difference in the guidelines of the treatment part of it. So if you're looking at the non-pharmacological treatment of dyslipidemia, the Indian dietary recommendations are similar to that of global recommendation. So point number one is that as the recommendations are similar, why should we call ourselves different? That's where I need to focus my attention. I think Dr. Raka should have something to do for the rebuttal of this. And look at the exercise recommendations. We need to exercise, be you are an Indian or a non-Indian, at least 150 minutes per week of a moderate to vigorous exercise does play a part in reducing your insulin resistance, so does the triglycerides. You don't have to do anything extraordinary to decrease the triglyceride. If I look at this audience of, we are say around 20, and I am sure that 80% of our triglycerides will be above 150 in a postprandial state. So, and the morning when you are going to check the triglycerides, I think there will be a small dip. The problem is what? Because we have been sitting in the hall for last 1.5 days without doing much, but then just occasional visit to the restroom as well as on the dining room. So the reason is our physical inactivity has led to high triglycerides rather than anything else. The insulin resistance has developed much early in our life compared to a Caucasian population. That could be the only reason that the drugs have not changed. Now let us look at what are the preventive measures between the Indians and Caucasians. If you are taking a good amount of, PUFA, I think that is, especially for vegetarians, that is quite advisable, because that is going to increase your HDL. But when I say PUFA, I mean that if you can take in natural way, as fish oils, rather than any synthetic products, they are going to reduce your triglycerides. And if you compare the major guidelines, what is the number one drug that you give for a patient, be it an Indian or a non-Indian? The first, what you call the tool that is going to be looked into is going to be your LDL. And what is the drugs for LDL? It is going to be statin. So is a patient, if a patient or a person of Indian origin is going to be not given a statin, but something else, I think I really beg that Dr. Raka has to find an answer. If that's going to be different, why didn't our treatment change? So if you look of all these guidelines, whether it is in ACC or ADA or the International Atherosclerosis Society, the first line of therapy is always statin. And if you look at the secondary prevention, you can see the very simple methodology by which you can treat a patient with dyslipidemia. So if your patient is already on statin, make sure that you change it into add-on, along with statin, probably estimib. Or if the patient is having no statin, start with an statin depending upon the LDL level, either an high-intensity statin or a low-intensity statin. And only when after 4 to 6 weeks, when LDL is not under control, you start moving on to the next level. And when you come to primary prevention, I think we don't change. Our guidelines are almost similar. You just look at the risk factors, whether it is a minor low risk or a moderate risk or high risk. Based on this, I think we have the LDL numbers by which you can start the treatment if required, or you can start with lifestyle modification alone. So you do have these goals, the treatment goals, as well as when you start the drug, it also based on your LDL as well as your non-HDL cholesterol. Is this different from any of the other non-Indian guidelines? I am saying it very strongly that we don't have anything that is dissimilar. So when you talked about diabetes, and of course, and India is only next to China when it comes to diabetes, I think we have this wonderful study called CARD study, which is again for the primary prevention, which was rolled out in 2004 and published in Lancet in the same year, where you have, which was seen that starting with that shadow, forget about the LDL cholesterol. The patient walks in, patient is diabetic, and you can see that atorvastatin of just 10 milligram was safe and efficacious in reducing the risk of the first cardiovascular disease, because this has proved that the atorvastatin reduced the death rate by 27%. And this trial was actually was terminated 2 years more earlier because of the report, and it was followed up for 3.9 years, and you could see that there was a reduction in almost 37 major vascular events for 1,000 such patients who were treated for 4 years. So be it a diabetic patient or a non-diabetic patient, starting with statin, you don't have to do lipoprotein small a, you don't have to do an ApoB, because that's not, for a population of India, I think almost 1 in 3 is going to be dyslipidemic in some form or other. And if you are going to want to reduce triglyceride, just reduce the body weight. How do you reduce the body weight? Lifestyle modification. You don't probably require a fibrate. And if the patient has to be dyslipidemia, do you have to be diabetic, improve the glycemic control. if you improve the glycemic control, automatically the triglycerides will drop. That's exactly you see in. So our drug treatment has not changed. Our exercise are similar. The guidelines are similar. Our non-pharmacological recommendations are same. The drug of choice is statin. So where is the cause? Concern of dissimilarity, except for the two pictures of two beautiful ladies that he has got, one tanned and other non-tanned. I don't see any difference between. Maybe that was a good capture for a poet. I think you can aspire, but I think when you talk about science, I think it doesn't have, the pictures don't matter. So management options are Indian. Statins are effective for LDL cholesterol, to reduce the LDL cholesterol. Fibrates probably are effective than statins in decreasing triglycerides, which are very high. When I'm talking about more than 500 or 1000, probably yes. The small niche of people, niche of subpopulation probably require fibrates. But where is the study? Field trial didn't give you any data on fibrates. So for effective management of high cholesterol, I think good glycemic control definitely plays a significant role. So this is the last slide. So apart from these considerations, I don't think that even though the Indians have circulating statins, do develop CAD much earlier than the comparative Caucasian population, we don't have anything to say that Indians are as good or as similar as non-Indians. Be proud of being an Indian. Jai Bharat.
Dr. Raka for the rebuttal, please.
Thank you, Dr. Jayakumar. Is this like that if land of law permits me for doing a crime to go to jail, then it's not a fault of society also that there should be a family counseling. So you are taking statin as a jail and you are universalizing it to everything. That if an Indian will do, he will also go jail. But we need to hope whether the parents are culprit or not. So हमें भारत के लिए कुछ नया सोचना होगा, and that's why we need a special theory that we need to be curtailing dyslipidemia and have high index of suspicion in our all patients. 3 or 4 slides only.
The laptop is gone. Yeah, it's not working.
Dr. Raka sir, you can just speak without the slides, is it possible?
Here's pictures. He tries some pictures.
Picture is bigger than speech.
वो साइड करके दो सर. जो अपने डाला वो नहीं आ रहा है क्या? वही तो है. क्यों? स्लाइड्स यहाँ पर स्लाइड्स वाज डिफरेंट. योर प्रेजेंटेशन हाँ वो सही था ना. हमारा तो सही था. अभी उनका जो पिछले वाला जो स्लाइड देख था ना, हाँ वो हमारी आ रहा है अभी. हाँ वो कैंसिल कर दिया उन्होंने.
Sir, food is the biggest addiction. And if your bakery chole is waiting to do damage to you, and what's the trend of obesity in children? If you are not going to teach our children that Sunday eating and Saturday eating is going out and taking chole and all good Indian food which are so addictive, and we take food as a legacy, forget about what Indians are there, settled anywhere where in the world with the Bima Indians or all society, and why paradox, why what had
अरे सर वहाँ से ने लैपटॉप ચાલતા જ નથી
are
હમણાં.
sitting with same BMI.
માઉસ અને લેપટોપ ચાલતું જ નથી અને એમને જે પેલા પ્રોજેક્શન મોડ પર નાખી દીધું હોય ને એટલે જે મેઇન એલઈડી સ્ક્રીન હોય ને એના પર પણ પ્રેઝન્ટર વ્યૂ દેખાય.
In India also, coast में पानी बदले हर coast में पानी.
हाँ.
Then we need to think of different way. And the risk of developing MI in individual cannot be exactly predicted by any test or any SOP protocols because we don't know when the vulnerable plaque will rupture. So I do agree with my opponent that we need to have same therapy of treatment, but we need to individualize. We can't say that my family is same family like Western family, and I need to design my own strategy, because the problem of the risk scores that the predict in 10-year risk is no way predict between 1D to 3650. So with this note, we are friends. It's all just Bansi Bhai setting. Today only we were going morning walk. So thank you.
अरे वो सर के पास ही
That's
रखो
very
ना
good. Any questions from the audience? Okay.
अरे अभी अभी वो नेक्स्ट स्पीकर का है रुको सर को दे दो वापस
In fact, both the
वो फ्लाइट
debates
वो
and the
जाके
results
क्लोज कर दो
passed
जाके
by.
ये पीपीटी क्लोज कर दो जाके
So basically,
अरे वहाँ पर
I
चालू है
think
पीपीटी
as we had the earlier meeting, that is, as
रुको
Asians,
कौन सा है
we have
राकेश सर
the
का
problem with the storage of the fat. And that must be taken in credence. And we have got genetic and epigenic phenomena where it is being particularly very individualized in our population, especially Indian population. And it is more food centric, as I told you. And definitely one needs proper lifestyle modification of diet and exercise, but more and above, the Indians have more of atherogenic lipid profiles, and also the plaque which is more vulnerable in most Indians. And so we need a very strict approach of hyperlipidemia in Indians compared to the Caucasians, because more than 40 to 60% of the global burden of CVD risk is in our country. So that is the reason why we need a special attention for dyslipidemia, and the management must be lifelong, or they won't live a long life. Thank you.
Thank you, sir. I'd like to discuss call upon Dr. Rakesh Parekh, sir, for the next talk, which is digital therapeutics for management of diabetes, and he's going to show us some hope. Dr. Rakesh, sir. Dr. Rakesh sir is a practicing diabetologist in Rajasthan, and he has multiple editorial and reviewer of various journals, over 50 publications, including textbook chapters. Over to you, sir.
Thank you, Shilpa, for these nice words. And let me first thank Dr. Rajesh Sabu for giving this opportunity. As it is customary for the conferences to have debates, we usually debate some topics which don't need a debate. Now, if you want to debate about the shape of Earth, again, that will be difficult. Now, today we are debating on a topic for which it would have been better if there was someone who is not tech savvy or who is analytic to talk against the motion. But we have Dr. Ajay, who herself is so tech savvy, and she uses earmarks, all gadgets, online consultation, and today she has to speak against the motion. So my compliments to her for taking this challenge. Now we move the topic. So digital therapeutics is a specific area. It's broadly called digital health, and out of that is digital medicine. And the digital therapeutics basically is the niche area where you are using softwares or apps for interventions, and these digital therapeutic tools, they require clinical evidence as well as real world evidence to be approved by FDA. So it's a specific area, and I hope we'll debate only on that and not on digital health or technology in general. So to define digital therapeutics, there is Digital Therapeutic Alliance, which defines digital therapeutics as the products that deliver evidence-based therapeutic interventions to patients that are driven by high-quality software programs to prevent, manage, or treat medical disorders or disease. Now, this slide I have taken from today's presidential oration by Dr. S.R. Arvind, where he has shown that if we look at the progress that we made in 15 years, from 2000 to 2015, we had so many new drugs, technologies, so many doctors now, and still the HbA1c status of our population is worsening. The number of people who are achieving the target A1C has gone down over the period of so many years. So what is the reason for this, despite having so many medicines? The reason is that the diabetes management is not just prescribing medicine. You need to involve the patient, and the patient has to be continuously involved in his management.
Now, we all know about the evidence that we have for the intensive lifestyle modification can work as good as metformin for prevention of diabetes. Now, one thing to highlight is that at least in our population, I don't know how many of you have time to spend half an hour or 45 minutes with a patient to educate him for in the first visit and do your best to make him motivated for lifestyle changes. And even if you do that, then how sure are you that the patient will come back to you? I think most of you will agree that half of the patients don't come back to you, and if they come back after 6 months or a year when the A1C has worsened. Now, what happens in between the first visit and the next visit that he comes to you? In between, he goes outside the chamber, then he has the mobile and the social media apps. He goes to home, goes on the OTT platforms, watches Netflix or Prime on his couch, and then he feels hungry and then he orders food. So food is also there available. So all the efforts that you took for 15-20 minutes of counseling, those are washed away, and the patient can never improve. Now, how do we take care of this, or how do we handle this problem? So if we can utilize the same technology and have some apps or tools that, rather than promoting this unhealthy lifestyle, might probably bring some behavioral changes in the patient and motivate him for a healthier lifestyle. So that is what is digital therapeutics. So these are basically web-based solutions or mobile apps in which the patients are actively involved in their own management. The patient's knowledge of the disease and the understanding of disease is enhanced. The metabolic status of the patient is monitored in real time on day-to-day basis. His dietary intake, physical activities, these are captured. Then these apps can be synchronized with the devices that the patients are using, the glucometers or the CGMs, and the other wearable devices that are nowadays available. And even there are apps that can give the automated doses for insulin recommendation. There can be personalized health coaching based on the data that is received by the software. And behavioral intervention is the most important aspect of this. Based on the inputs that they get from the patient, the personalized coach gives the specific interventions or advices for the lifestyle modification, and this goes on. It's not just one time, it goes on for the period of time. And these are all evidence-based interventions which are given, and the doctor gets the real-time feedback. So this is what is taking care of the gap that was there between the patient and his next visit to the doctor. So that time, rather than going on OTTs and the food delivery apps, he goes to the healthier apps. Now, so how will it help us? It will improve the patient's engagement. Now, once you involve the patient in his own treatment, definitely that boosts the morale of the patient. The self-efficacy of patient improves. The adherence to therapy goes up. The glycemic status improves. The medication requirement goes down. There is evidence to show that the patients who are on such interventions, their medication requirement goes down. The cost of therapy goes down. There are less frequent visits required. The healthcare resource utilization goes down. And let's understand that this is just an assistant to us. It's the digital therapeutics is not your competitor. That's a tool at your hand for helping you. Now, these are several apps. I'll not go through all these things. You know that there are apps for which are on nutrition, physical activity, on glucose monitoring, on insulin initiation, insulin doses, and so many. And they all have the softwares in which the stakeholders involved in the patient's care are on board. So the doctor, the patient himself, the health coach, the different devices that the patient is using, these all are in the ecosystem. The whole data from the patients is captured, and based on the evidence, the individualized, personalized advice is given to the patient. Now, we all talk about evidence-based medicine, but then let's agree that there is so much of evidence being generated, the number of publications that are happening. It is really impossible for any of us to keep track of all the new things that are happening. So why not take the help of computer for that? Why not just accept this computer and this software as a friend rather than thinking him as a competitor to us? So before Dr. Anjali comes in, let me say that I am not saying that the software should replace a doctor. He cannot be a replacement for us. He's just a friend. He's just a tool that we can use. There are several such digital therapeutic options which are available. These are a few to name in the field of type 1 as well as type 2 diabetes. And this is the trend of clinical drug trials that are being done in this particular field over a period of last few years, the academic trials as well as the industry-sponsored trials. And these are the different countries in which the trials are ongoing right now. And this is the kind of money that is being put by the investors in this. So let's accept that the investors are definitely very smart and they know where to put their money in. So this is the upcoming field. The future is of digital therapeutics. And there are so many startups who are working on this field. I could just put these many logos in this slide. And these are the well-known pharma companies that we all know. They are having ties with different products. These are all digital therapeutic products which are about to be launched in the market very soon. And then Dr. Anjali would ask me, where is the evidence? So there is a huge evidence. This is a meta-analysis showing all these interventions improving the patient's A1C. And the list is very long. So I'll just skip through the slides. These are the trials in which you can see that not just patient's A1C goes down, patient's weight improves, his quality of life improves, his TIR improves, and so much of evidence here which I can't cover in 10 minutes. And then let's not forget the closed loop devices that we have now, where again we are using just a software or an app or a loop to predict the development of hypoglycemia in future or to suggest the patient the insulin dosage that is required. So this is the future. In the future, we'll have all these wearable devices which are connected to each other, which are talking to each other, which are generating the data from the patient's devices, and based on the evidence, the computer will give some advice to the patient, which will be an ongoing process. It will not be one visit in 6 months, but it will be happening on day-to-day basis. And I think Dr. Anjali should, accept this, that the technology is there to come, and it will be better that she accepts the technology as a friend and not as a foe. Thank you.
Thank you, sir. Dr. Anjali, ma'am. She's an MBBS and an endocrinologist and a diabetologist, chief founder and consultant at Endoclinic, Pune. And she's passionate about patient care research and teaching and formula curricula for various courses and community-based activities. Over to you, ma'am.
Dr. Anjali Bhatt. Yes.
हाँ ऑनलाइन बंद हो जाएगा That's it.
Very rightly, Dr. Parekh has said that I am a very techno-savvy person and not at all against technology. But we are not talking about technology. We are not even talking about digital health. We are talking about digital therapeutics. And this is something that we need to understand before we even say whether it is hope or not. And that is why we'll take this talk with an agenda of understanding what is digital therapeutics, what is not digital therapeutics, striking example of the biggest failure of a huge digital therapeutic company who is US based and had all the money on the earth. And I will tell you what happened with this company. What did we learn from this failure when we apply digital therapeutics to diabetes? Because we are talking about digital therapeutics in management of diabetes. What is hope and rest all is hype. So we are going to understand what is hope in all this, and rest all is going to be the hype. So as Dr. Parekh rightly told us, the definition of therapeutics by DT8, Digital Therapeutic Alliance, we'll come back to this. Before that, the definition also mentions that it not only complements but has a potential to significantly replace the existing system. We do not feel insecure at all because we know this is not true. This will never happen. This is not going to happen. So there is no question of insecurity. It is only question of understanding what is told to us and what we really know about it. What is not digital therapeutics? So having looked at the definition, which is, we'll come back to this again, evidence-based therapeutic interventions driven by a software to treat, prevent or manage a medical disease. Now, what is not therapeutics? Teleconsultation, audio video is not a therapeutic. Wellness mobile apps are not digital therapeutics. Medication reminders, smartwatches, speedometers, electronic medical records, digital sources of information like articles, blogs, videos, images, whatever you are reading on the net as an information is not digital therapeutics. Digital diagnostics, including continuous glucose monitors, glucometers, the applications which give you an ambulatory glucose profile, are not digital therapeutics. Digital pills even are not digital therapeutics. So what is digital therapeutics? As we saw, it is an evidence-based therapeutic intervention that is driven by a software. What does that mean? That it exclusively relies on an algorithm for its mechanism of action as well as suggesting the management. So this is an expected design of a digital therapeutics. This is a slide which tells us what will digital therapeutics in diabetes look like. Patient feeds the data, everything, food, exercise, medication, hypoglycemia, even glucose monitoring. I'm sure patient will watch Netflix, patient will order Zomato, but he will not enter what he has done, neither on app nor in front of the clinic. So this is what the patient needs to do at baseline, that he has to enter everything that he is doing. Then there will be, based on a large amount of data provided by the patient, the software will make an algorithm and it will learn what to give back to the patient. On what basis? Based on a large amount of data that is fed by reference texts and experienced experts like doctors, nutritionists, physiotherapists. They will provide their expertise, patient provides their data, and then a smart algorithm learns what to tell to the patient. So this is what digital therapeutics is all about. And then patient implements that data and comes back with a result which is improvement. And that has to be done with no or minimum real-time human involvement. You can't have a doctor sitting at the other end of the app to do this. That is not digital therapeutics by definition. The doctor has to only tell once to the software what the software needs to do, and later on the software is supposed to do it on its own, adding his own artificial kind of an intelligence to it. So this is what a digital therapeutic is. This has to go on for generating the evidence, and after generating the evidence and after proving that it is useful, it has to continue to do that. The main crux here is algorithm. Now I spoke to the CEO and creator of a large successful digital tech company, not digital therapeutic company, a digital tech company. This is a technology guy, and he told me that if you want to use algorithmic artificial intelligence in therapeutics, you have to have a disease that is well defined, that is repetitive, that is homogeneous, and that is bounded. And believe me, diabetes is nothing like this. Diabetes is extremely heterogeneous in terms of its pathophysiology, whether it is genetic, environmental factors, day-to-day behavioral factors, cognitive factors, everything is heterogeneous. Not only that, with the same patient, not all doctors have their own consensus on how to treat the patient. So the disease itself is heterogeneous, and on the same disease, different doctors have different opinions. So forget about having a consensus and giving it to an algorithm who will work on it. So it's an extremely heterogeneous process. A digital therapeutic algorithm in such cases is not only difficult, it's almost impossible. Now this is the biggest example of the biggest failure of digital therapeutic app, and this is called IBM Watson. This came up as one of the very huge player in digital therapeutics. This company had many billions of money put in this company, and what the company did was that it was sold in parts, it was sold in pieces. The data was sold to someone, the app was sold to someone. They put in many millions. The number is not exactly out, but it is somewhere around 7 to 8 billions. And it was sold for 1 billion. So all the money that they are putting into technology, and they are telling us that the market is going up and up and up, this possibly is a future of the money that you are putting into digital therapeutics, unless we know what is hope and what is hype. I would not be doing justice to my personality if I use these things. I don't like to use these words, but this is what a word which is used by Kaiser Ross, who was a technology correspondent who was following up what is happening with IBM Watson, and this is what he told about IBM Watson, that it is a piece of shit. So that Watson had, there is a long interview between Ross and the therapeutic technology person. I've just taken snippets from it. What he said was that the Watson had trouble with the complexity of patient files. We know how troublesome these patients' files are, and if we are going to believe on digital therapeutics, this is what is the future. Another word that he said, that I think the marketing got way ahead of the capabilities, and I think this is what technology guys try to do. They try to get into your mind, market it so well to you that you believe to what it is not. And that is what we have to be worried about. It is not against technology, it is not against digital, it is against telling us what it is not. Again, I had a discussion with a very senior level expert in diabetes who is working with a digital therapeutic kind of a company in India. Both of these people told me not to tell their name, otherwise I was planning to give their reference, but they told me not to use their names. Good, the presentation is going on, very good technology. People are not techno-savvy. This is what she told me. We can of course know that these things will change. There is a hope that people will become techno-savvy, but right now they are not. People still want human interaction. People do not upload the data. They eat everything, they comment, they tell you, but they will not upload in the app. Symptoms can be vague. मराठीत आमच्याकडे पेशंट आहे कसं तरी होते म्हणजे काय there is something happening, I don't know what. So how do you explain this to an algorithm? I don't know what is happening. So this is, symptoms are very vague in diabetes. Momentum fades away. In the initial part, people are very happy, they got a toy to play with, but later on it fades away. Self-motivated people do well. They do well without even digital therapeutics. Double work for dietitians and doctors because they are entering the data and then again they are talking to the patient also. Maybe good for prevention, but not for therapy. Patients are very, I would be very scared to let a computer algorithm manage my patient's hypoglycemia. A lot of resistance from the doctor's side to rely on software for the sake of patient safety. Some more unforeseen reasons. Technology is ever changing. By the time you create an evidence, the software is changed. All the the software list we have of digital therapeutics, now the software is different. The evidence was for some different software. It requires regulatory authority. By the time regulatory approval is done, the software is changed. Metformin remains metformin till the approval and thereafter. But the technology changes very far. If the approval is not mandatory for sale, then the definition itself is hyped. If it is not regulated, it is not evidence-based. Some of them may have quality clinical research data, and in United States, they are struggling to keep up with the volume. With the kind of regulatory obsession US has, if they are not able to deal with this, forget about us being in the regulatory position of seeing what exactly these apps are doing. Technology guys are restlessly fast. The health doesn't move forward with that speed. It should not. So by the time the way the software changes, the health aspect of this industry, if I may call so, is not going to move that fast. So the digital world moves fast. You can't change the product so much that it is no longer doing what it was cleared or the regulation was done for that. Data protection, again, one of the very good foreseen problem. Constant observation and profiling of the patient. Rather than telling the patient that if this is increasing your blood sugar, don't eat this. There is a possibility that the market will tell you, this is something wrong, this is what we have to make it correct. So we have to be very sure that we are really taking the patient data and telling the right answer to that. There is a very big possibility that this data might be misused for commercial reasons. High potential of personal data breaches. The major threat to a person concerned. There is no end to what the data can be used for. And these softwares are so complex that they can be easily bugged. And anyone can control the algorithm. So what is the hope?
Excuse me, ma'am.
Yeah, this is the last slide. Not possible to replace the cognition is something we have to understand. Can you tell me what is this? What is the picture? Cat. Can you tell me why do you say it's a cat? There is a? Right. And we don't know how. We don't know how we recognize that this is a cat. We know there are 2 ears, we know there are fur, there are so many animals with that. And this is cognition. And the artificial intelligence or algorithm, we don't know how it does it. So that is a very risky thing. So there is a hope for vision, image reporting, very good, computer can do it. Speech, tireless talking. We get tired after talking to the patient for half an hour. Patient needs more talking. The Siri can do, Alexa can do. Electronic aids for repetitive procedures. The things that are coming again and again, that where there is no cognition required. This is hope. Rest all is hype. So we don't need to make a foe with technology for sure. This is a very famous slide, all of us must have seen, that in 1990 the technology was fatter, we were thinner. In 2020 the technology became slimmer and we became fat. But we need to be smarter than these smart devices that we have made, and we have to know what is hope and what is hype. We need to be thin and use the technology the way we want. We should be in charge, not the software. With that, I come to summary. We saw what is digital therapeutics. We saw what is not digital therapeutics. Don't call this digital therapeutics. This is digital aid to the therapeutic, which is fine. We have seen the biggest failure. If IBM Watson cannot make it, small companies are very unlikely to make any commercial profit out of it. And we need to be smart and know what is hope, which is small, and rest all is absolutely a hype. With that, I'll rest my case.
Thank you, ma'am. Rakesh sir, rebuttal.
Thank you, Dr. Anjali. It was expected that it would be difficult for you to speak against the motion. So, anyways, you guided very well, but you just changed the definition. So, she very smartly said that this is not digital therapeutics. So, if we are debating today about 5G, she would say that 5G has a hope, but you can't use it on mobile or internet. So, that is what the analogy is. Now, the definition of digital therapeutics and all the products which are there, they are all using the different gadgets. The gadgets are the source of inputs. You said that we have to make the entry. Now, tell me one product, one digital therapeutic product where the entry is made manually. All the products which I listed, they all are taking the inputs from the sensors and the wearable devices. Nobody makes the entry, otherwise it's a user job, so nobody will do that. Now, you said wellness apps are not a part of the digital therapeutics. In fact, all the wellness apps, a few of them are now even approved. Wellness is one of the FDA approved therapeutic app, and it is a wellness app. So, you try to change the definition. Then you said that there will be regulatory problems. So yes, regulatory requirement is there, and FDA is working on that, and it is approving only selected products as the digital therapeutics which are FDA approved. Software changes would happen, let the developers take care of that. They are putting in money, they are putting billions of dollars. They know that software can change and they will change it. Then I think you ultimately agreed that there is a hope. You said that there is a hope, but you said that let's not be very fast. Now I can't wait. Like, type of patients they had a moment, we can't wait. Similarly, we can't just wait. The product is there. The product is FDA approved now. We can't just wait to satisfy ourselves and sit for years and then we'll join the movement later on. We are fast. We should take all these things. You showed a very good example of a cat population. Now the AI is so developed that it can identify not just cat but your fundus. It can find out the minute changes in your fundus. So the softwares are developed, the wellness apps are there, the products are there, and I think there is a hope that you agreed to. Probably you wanted to be a little careful and not be fast, and probably the young generation wants to be fast and adopt the technology very fast. Thank you.
Thank you, sir.
No, I think the whole concept of digitalization, the virtuality, and the computer usage for the clinicians came into existence after the outbreak of COVID. And in fact, these recent developments have changed the entire profile of this thing. So unless that you have an access or you have got the digital knowledge, most of the patients may not have a digital knowledge, or they don't know how to use the computers or the iPhone or any Android phones, and how far they can get into the real usage of exchanging their complaints or the doctor explaining the treatment for the patient, and how long they can spend time and how far it is going to be remunerative. Though it is very useful because the patient is at one side and the patient doesn't need to travel a long distance, and economically it is more viable for the patient, and it solves a lot of problems economically, because without going to the doctor's consultation room, they can get the treatment part of it. But in all sense, the patient needs the physical contact, the physical look, the physical touch, and also the physical conversation in close quarters, and that will solve a lot of problems for both the patient and the doctor. Thank you.
Thank
No.
you, everyone.
So,
Now,
so you have a
I would
presentation?
invite our next
5:30.
chairpersons,
Disconnected?
Dr.
क्या तो
Prasad
बोलो ना.
and Dr. Vikram.
अरे मैं ये बोल रहा हूँ वहाँ पर पेन ड्राइव नहीं लगी है लैपटॉप में. हाँ तो लेके आओ अभी टाइम में जाओ जल्दी जल्दी पेन ड्राइव लेके आओ. हाँ अरे ले आओ ब्रेक नहीं है पेन ड्राइव लेके आओ. तुझे यही कर इसको चेक करो ये अभी बंद नहीं होगा.
At the outset, I would like to thank
ये चेक
the
नहीं होगा.
organizers of Diabetes India for
और ये चेक करना है मेरे को. है
this
दूसरा पॉइंट.
wonderful opportunity to chair this
अच्छा हाँ फ्रीज
session,
कर दिया
an
तुमने.
interesting debate session. And we see that the previous session of debates were of mild to moderate intensity. I expect this session to be moderate to severe intensity, seeing the set of topics and the speakers. So without wasting much of time, we will go into the session.
अपने पास इसका आएगा खाली देखो अपने पास. ना ये नहीं. हाँ ये रहा अभी अपन यहाँ से चालू. जाओ जाओ रुको रुको जाओ जाओ.
Recipient of Award for Excellence in Diabetes Care by RSSDA in 2019. He is also a member of American Association of Clinical Endocrinologists, also part of Committee for Diabetes, Obesity and Thyroid Disease Network at AACE. He is working as a diabetologist and endocrinologist at Desai Diabetes and Endocrinology Clinic and Advanced Diabetes Center Surat, and also attached to the Government Medical College Surat as an honorary endocrinologist. I would like to request.
मैं ये फंक्शन फ्रीज करके रखा है इसका.
So I will definitely assure, and I think my good friend Tejas and Purvi is also there, that we will make this not moderate, severe intensity. So I am going to talk on SGLT2 as a second add-on to everyone, any type 2 diabetic patient. And actually, why should we debate on this? Because there is nothing left for the opponent to compete. It is like our Prime Minister Narendra Modi. He is everywhere and he is for everyone. Similarly, I thought that if any patient coming to my clinic and if patient is already on metformin, lifestyle modification and uncontrolled, which type of different patient profile will be there? And is there any evidence that I will put SGLT2 as a second drug to that patient? New onset type 2 diabetic patient, multiple risk factor patient, prior MI, ACVD, CKD, heart failure with reduced ejection fraction, heart failure with preserved ejection fraction, even type 1 diabetic patient and pre-diabetes. I will take you through this. Mr. Suresh, first time diagnosed, 8.5 HbA1c. I know that metformin alone is not going to work and patient might go into metabolic syndrome. I want drug in form of SGLT2 which is not only glucose lowering, it is having insulin independent action, it is having osmotic diuretic like action, it is having action which reduces visceral fat. That is exactly what our previous session was on about lipodystrophy and external lipodystrophy, along with hypertension and reduction in CVD risk factor, which is exactly our thin fat Indian Asian phenotype deserves. And if metformin is already there, which is there in first, DPP4, good drug, silent drug, mild drug, not causing any disadvantage, but it is also not giving any advantage also. Pioglitazone, good drug, but still you have to be cautious. Sulfonylurea, I think Tejas will talk on that, but it is not the second add-on we wish for. Then what is left? Glycemic control, weight loss, blood pressure, lipid profile, everything is covered with this miracle drug that is SGLT2 inhibitor. and along with that it gives anti-inflammatory action. Over the top of that, it reduces liver fat content, exactly what Dr. Yajnik and our previous speaker was talking about, that fatty liver and its consequences is going to be a problem. This drug works on that. If patient is having risk factor, if patient is having eGFR which is low or microalbuminuria present, we have study in form of DECLARE where 2/3 of the patient were having multiple risk factor and not an established disease, and you can see this, that even in that patient it has found to reduce mortality and hospitalization of heart failure. So as we have renal composite endpoint which was also unfavorable, where patient was not having any established cardiovascular disease but a multiple risk factor. And if patient is having MI, we have EMPA-REG, we have DECLARE, we have CREDENCE, we have VERTICIVI, we have CANVAS, we have number of study, but EMPA-REG has shown excellent benefit, and so as Dr. Subodh Verma's paper, that it works like AC inhibitor, it reduces remodeling rate, it reduces LV mass index, that happens with empagliflozin and mostly with other SGLT2 inhibitor also, and that's why cardiology conferences and cardiologist association has taken this drug as not only second line along with metformin and maybe before metformin whenever it is indicated. Now I come to CKD. Patient already having CKD, patient already having eGFR which is reduced. Do we have data? DAPA CKD has shown us the data that it has shown excellent benefit. So as we can see the similar benefit in all other trials with SGLT2 inhibitor. EMPA-REG study, one subset analysis has shown it maintains eGFR. Though there is an initial dip, thereafter it maintains eGFR, and patients who were on EMPA in comparison to placebo, there was significant reduction in renal composite endpoint. And similar finding was found in even EMPEROR reduced also. And that's why in KIDGO guideline has also put this drug just after metformin, along with metformin, or maybe before metformin, and all rest other drugs which are used in anti-diabetic medicine are third, fourth, fifth, sixth, whatever you want, but first two is metformin and SGLT2 inhibitor. And similarly, reduced ejection fraction, we have DAPA-HF study, and I think this is not unknown to this august audience, so I will not take further. But now we have data with preserved ejection fraction. You can use this drug, and this is the single drug which has data which has shown reduction in hospitalization heart failure even with preserved ejection fraction. Now what about pre-diabetic? Even in DAPA-HF study, we had one subset of patients who were pre-diabetic, and there was reduction in incidence and occurrence of diabetes which was reduced in DAPA arm in comparison to control arm, which suggests that like metformin in DPP study or maybe rosiglitazone study, or wherever diabetes prevention program, we have number of study for prevention of diabetes. This is also one of the drug you can utilize for the benefit. What about type 1? In India, it is not approved, so don't take this with a pinch of salt. I am not saying this is for everybody, but DPIC study, here metformin is not the first drug. Insulin is the first drug, and if you want to have second add-on, can we use this? We are nowadays using metformin in many type 1 diabetic patient who develops insulin resistance, so as this drug also reduces insulin requirement in type 1 diabetes. It controls HbA1c. We have DPIC-1, DPIC-2 study, and adverse event was not that much. So when we are talking about SGLT2, because it is comparatively new drug, we think this is a new drug. Do we think as a second line just after metformin? Metformin is a time-tested drug. But first step to establish that something is possible, then probability will occur. And exactly happened with this SGLT2 over the period of 2015 to 2020 to today. When we are talking about SGLT2 inhibitor, we have number of evidences available for heart, kidney, heart failure, and everything. And that's why our ASE and ADA guideline has been changed. And ADA-ASE, ESC guidelines suggest that you should use SGLT2 early in patient with established CVD or multiple risk factor, fine. You want weight loss? Fine. If you want no hypoglycemia or less hypoglycemia, fine. Then there is one part that cost is an issue, then SU and TZ is there. But in India, when we have SGLT2 inhibitor which are cheaper, I think that is also included. Then what is left as a second choice? It is just metformin, and thereafter this is the first, best and last choice to add on as a second patient. And so as AAC inhibitors, AAC guidelines are also saying the same. You can use as double, triple therapy or even with insulin whenever entry level HbA1c is high. But I know my opponent is searching that where it will not be. And on the other side, cardiologists, nephrologists are taking this molecule as one of the best choice and as an alternative to even metformin. And in diabetes, we are still thinking, do we use this drug as a second line? Why to wait as use this drug as a second line? Yes, there were few points he will definitely take out that we cannot use in pregnancy, we cannot use in patient with LADA or insulin deficiency, or patient having multiple recurrent fungal infection, UTI. How many patients in your clinic are going to be like this? 5%, 7%? I will say less than 10%. So, I am talking about 90% of your patients you are seeing in your clinical practice who can be benefited with SGLT2 inhibitor. So in corona, we come to know that mask is very important and diet is very important in diabetes. So entry is important. So as exit is also very important. Metformin has shown glucose excretion in stool, which is helping us to reduce that. And similarly, pink sugar because of SGLT2 has caused miracle. So if you expect the unexpected, then you will win. Or I could either watch it happen or just to be part of it. So I will tell you, all of you, to use SGLT2 inhibitor as a second line drug and be part of it. Thank you.
Thank you, Dr. Piyush, for that wonderful lecture. Next, I call upon the second speaker, Dr. Praveen Kalvit. He has his MD, FICP, and FRSSDI. His present designation and affiliation is Senior Consulting Physician and Diabetologist at Kalvit Nursing Home and Infertility Center, Bilaspur. His areas of interest include diabetic food, diabetes education, metabolic disorders, and insulin therapies. He has been the organizing secretary of CG Epicon 2004 and CG EPI 2005-6, and founder chairman of Bilaspur Diabetes Society, editor of education book on diabetes. He started the first insulin bank in the state of Chhattisgarh and second only in India in 2012, and received Distinguished Physician Award from RCP London. He also holds membership to professional bodies like API, RSSDI, ADA, EASD, IDF, and ISCCM. Over to you, sir.
So at the outset, I would extend my heartiest thanks to organizing team for giving me this opportunity to be amongst you today evening to make a debate. This is actually what the audience really wanted, and it wanted to be firesome. There has to be some fire in the debate. Let me concede at the outset, my esteemed opponent has already used all the parameters and all the resources available at his disposal to prove that whatever he said is ultimately true, but in fact it is not. And why it is not, which I am going to tell you. Whenever we talk of debate, debate is something like we have to contest the issue. And I always am the thought that debate is much better than denial. Secondly, it's better to debate a question without settling it than to settle a question without debating it. That's what has been happening here. And debate and divergence of views actually can enrich our knowledge and perception of the subject. So looking into this, my aspect today is going to be cons about SGLT2 as an add-on to metformin whenever we think of add-on therapy to metformin. Fundamental tenets of management of diabetes is restoration of euglycemia. The concept has changed from just management of triumvirate of glycemia from disturbed prandial, postprandial blood sugar level, fasting blood sugar level, and then glycated hemoglobin to what we have been addressing to what is called as the physiological defects, addressing the defect, the famous concepts of ominous octet laid down by Di Fronzo. And if you try to take into consideration every single pathophysiological defect, you know the drugs which are effective at each and every limb of the pathophysiological defect, and here in this chart you can find where is the position of the SGLT2 inhibitors. In the outermost, lowermost quarter, where it just prevents the reabsorption, it causes increased glucosuria, it causes glucosuric effect. Barring this pathological defect, all other effects which are taken care of by the drugs other than belonging to the category of SGLT2 inhibitors, so with propriety we can say this is a drug of choice as add-on to metformin. What makes a drug desirable for the add-on combination to metformin? Basically, a drug which has got the capability to answer all pathophysiological processes underlying type 2 diabetes. It should have a predictability in reducing of the blood sugar. It should have wider indication, should be used in a very extreme spectrum of the disease. It should have durable and a very low secondary failure rate. It should be tolerable than other drugs. Then it should have no clinically relevant side effects. Then it can be used in various combinations, and it should have some benefit in some comorbid conditions also. Now, if you have various drugs which are being used in management of hyperglycemia, what you find here amongst the chart is the different issues like defects which are addressed to a maximum extent by drugs belonging to the category of metformin and DPP4. Where is the status? What is the level at which SGLT2 are found to be acting upon just by reducing glucose reabsorption from the tubules, PCTs? That's the only pathological defect which it is supposed to address. Rest all effects have been very nicely and very elaborately addressed by the drugs belonging to the category of OHS, different from SGLT2 inhibitors. So in the backdrop of such a situation, how can emphatically we say that SGLT2 remains as an add-on to metformin? I would say no, there are several other drugs. Then, and no sooner this baby of SGLT2 was born, you know, the threatening calls or alarms had already started percolating from the parent organizations like FDA, wherein it started thinking about the serious infections, the genital infections, which has been undermined and underscored by my esteemed opponent. The incidences of leg and foot amputations, then severe urinary tract infection, urosepsis, euglycemic ketoacidosis. These are not something, see, basically in clinical practice, whenever we try to treat our patients, we try to treat patients with a holistic approach and not only with glucocentric approach. So whenever we think of holistic approach, we have to take consideration of all these points which are very, very important in management. There are distinctive risks associated with SGLT2 inhibitors like DKA, one of the threatening complications. Severe renal adverse effects, genital urinary infections, cancer risk, foot amputations, bone fracture risk. Then SGLT2 is associated with DKA, and this association is not limited to particular demographic profile. It is found ubiquitously. In Caucasians and Asian Indians also it is found. It increases the risk when further combined with DPP4 inhibitors. And SGLT2 actually deprive the cells of glucose supplementation. It causes decrease in ketone excretion, causing severe ketosis and euglycemic ketoacidosis we already made a mention to. It causes significant medullary hypoxia, which is a great concern, and that's the reason why as soon as you initiate the SGLT2s to a patient of diabetes mellitus, it causes a transient dip in the eGFR. And normally my opponent has taken this issue very lightly, but patients who are on the end stage of renal disease, stage 3, stage 4 renal disease, this transient dip could be extremely detrimental to the patient's condition. Then it causes under some situation reticular renin-angiotensin system activation. The genital infection and the urosepsis, you know, it could be very, very fulminant and sometimes life-threatening if the patient is using SGLT2 inhibitors. Think about the cancer risks. Experimentally, high doses of dapagliflozin up to 2 years have been contributed to cause increased tumor incidence. Canagliflozin has already been blamed for causing bladder cancers. And SGLT knockout mites have also been shown that they are now deprived of getting cancer infections because their receptor blockage has already been carried out. So there are differences between experimental and clinical evidences of carcinogenicity induced by these SGLT2 inhibitors. Although we say that this cancerogenesis or carcinogenesis is not an individual drug, it's not a class effect. The cancer effect is attributed to different individual SGLT2 inhibitors. Foot and toe amputation, twice is the incidence, twice higher is the incidence of foot and leg amputation in patients. Bone fracture risk because of the significant hyperphosphatemia and the inherent tendency of SGLT2s to decrease the mineral bone density, that has also been blamed for. Significant volume depletion accounting for severe incidences of strokes, syncope, hypertension, and a patient who is already critically ill and having severe dehydration. Then euolic patients, we have to consider the reducing doses of diuretics, which is an add-on therapy for management of patients with congestive heart failure. We always say it's a drug which is used in half-ref and half-pref both. But then these patients who are on concomitant diuretic therapy, one has to be extremely cautious in titrating their doses. SGLT2 inhibitors should be withheld with the risk of dehydrations in individuals who are critically ill. And once in a while, in a lifetime of every diabetic individual, he has to go through phases of severe critical infections. You have to be extremely cautious using these drugs. Hypertension has been made mention of several times because of volume depletion and severe dehydrations in individuals taking SGLT2 inhibitors. It causes slight increase in the hematocrit, higher incidence of UTIs, higher risk of amputations, polyuria, dehydration, and even to some extent it has been blamed to cause slightest increase in the LDL concentration also. So there are distinct no's with SGLT2 inhibitors, don'ts with SGLT2 inhibitors. Do not initiate SGLT2, that is EMPA, as one of the component members. EMPA canine DAPA with eGFR less than 45. My opponent opponent has given a slide wherein he said metformin not to be initiated before 45 eGFR. But these drugs, the SGLT2 inhibitors, there's a warning not to initiate the drugs when their eGFR falls to less than 45 milliliters. Then do not start. There's a different class of drug. For a higher cutoff, it has got a higher cutoff of 60 ml per minute per 1.73 square meter surface of body area. SGLT2s are contraindicated with eGFR of less than 30. There's absolute contraindication. So this is one of the, and in the contrast, I would like to tell you there are several other drugs belonging to different OH categories, including DPP4 inhibitors, where the usage in patients with CKD is not absolutely contraindicated because these drugs will also be used in patients who are being hemodialyzed. Avoid SGLT2 patients in tendency of recurrent urinary tract infections. And of course, they are not, people are using, but they are not officially approved for usage in type 1 diabetes. People are making use of this drug as off-label therapy. Then what is the status of SGLT2 in today's scenario? For you to initiate SGLT2 in any patients with diabetes mellitus as an add-on therapy to metformin, the patient must satisfy one of the following conditions: that he has got inadequate treatment response to available OHs, or he is intolerant to available OHs, and is contraindication to metformin or any one of the following conventional OHs which is being used, including DPP4s, TZDs, GLPs. Patients must have a HbA1c greater than 7. Normally, we know that for individuals with a presenting A1c of less than 7.5, effectivity of SGLT2 is overscored by other available drugs, including gliptins. If the patient has got GFR of more than 60, then you are at a comfort zone of utilizing this drug in initiating therapy, and there is no dual therapy with SGLT2 and DPP4. Of course, whenever you are initiating, you have to be little cautious regarding the side effects which are most foreseen. So we have a definite take home when we think of using SGLT2 as an add-on. I would say emphatically no, wait, because there are several other choices. We are actually, when we describe these drugs belonging to category of SGLT2, what we say is we are actually in the midway in discovering the reality of SGLT2 inhibitors. We are not fully through it. We are actually in the midway of discovering the reality of SGLT2 inhibitors regarding their risk and benefits and full safety profile. Until that, the use of SGLT2 inhibitors should be limited to their specific indications. It is being used, it can be used continuously, but there are definite stipulated set of indications where the drug can be used very comfortably and very confidently. After initiation of metformin, consider GLPs as one of the most promising drugs for prevention of cardiovascular disease, atherosclerotic cardiovascular disease.
So we are running short of time.
Yeah, last slide. And DPP and SGLT2 inhibitors could be used in patients who have got cardiovascular morbidity or renal involvement associated with diabetes only. So with that I conclude. So I would take home is there is no single size that fits all combination. Metformin along with SGLT2 or metformin along with ACO or metformin along with DPP4. This single size combo does not fit all. Every therapy has to be individualized, and every diabetic patient has to be given credibility of getting management on individual basis rather than making a generalized statement that this is the definite add-on therapy to metformin. With that I conclude. Thank you.
Thank you, Dr. Parveen. But I mean, this is the debate, and debate is of 25 minutes. So the first speaker has to speak for 10 minutes. The second one again will talk for 10 minutes, and there could be rebuttal of 1 minute again, and then the final conclusion if anybody wants to make any comment. So it has to be restricted. I request chairperson for the next debate, make sure that the first speaker speak only for 10 minutes and the second one will only for 10 minutes. It is strictly to be 10 minutes, and then we have to stop so the rebuttal can again be done, and then we have to, because otherwise debate will not have any, it's like a lecture. So please, thank you.
Any comments from Piyush sir?
I would again emphasize my second last slide, that we are talking about only side effect as my opponent does. But what about effect? What about the benefit of this SGLT2 inhibitor? Are we going to see that 10% or are we going to benefit 90% of our patients? That's all.
Thank you. For shortage of time, I would like to get an audience poll on this topic. So how many of you go for that first? Yeah. Yeah. How many of you?
It is, suppose 90% was originally in favor of SGLT2 and only 10% was against it. But suppose he had changed from 10 to 12, then still he is the winner. The point is, because he could convince 2 more persons.
So,
that's the right way of answering.
So, how many of you are in favor of SGLT2 as the only add-on for patients with, all patients with diabetes? How many of you are as the first add-on for all patients with diabetes? So, how many of you are against that? Yeah, I think it.
So there are many who are not raising their hands. They have some other opinions.
I think we will quickly move on to the next session, which is.
So for the next debate, I just how the voting to be done. The preventing diabetes complication, 100 years on from insulin, which of the given choices will prevail? Is it GLP-1 versus SGLT2? Now Dr. Arvinda is going to talk in favor of GLP-1 and Dr. Puri is going to talk for SGLT2. Now it should be in advance, how many of you are in favor of GLP-1? Now that we have to count. So how many of you are going to, yes, for GLP-1? Only 1, 2, 3, 4, 5. Okay, so 6, 7 people are there in the favor of that. And for SGLT2, how many of them are there? So suppose 20 are there in favor of SGLT2. Now the point is that GLP-1 at this point in time only 6%. If Arvinda could convince after the debate from 6 to 10, then he is the winner. Yeah. So that's more important. Even before starting the debate, only 6 was in the favor of GLP-1. And after the debate, if 10 of them, then he is the winner. Okay, so I'm not just saying that he is the winner. Come on, we have to try. And now, all yours. Dr. Arvinda is senior diabetologist from Mangalore. This is sufficient introduction for Arvinda. Start.
हाँ वो तो मैं उसको देख के ही मैंने ऑन किया.
So good evening everybody.
At the outset, I thank Dr. Arvind sir, Dr. Banshi sir for giving me an opportunity to debate in this wonderfully organized conference. So I'll be talking in favor of GLP-1 RA. So first of all, greetings to all of you from Bangalore. I'll tell you a story actually. See, there are two recent movies which was released, which were the blockbusters actually, Triple R and KGF. But which one is better? That is the question. Obviously, KGF made a big name, big money because of its technology, acting, everything. So it was a super duper hit. We all agree on that. So in the same way, Dr. Purvi is supporting Triple R. So I am doing KGF, rebuilding an empire. So if you go this, see this mechanism of action of anti-diabetic drugs. See SGLT2 inhibitors, only on the bottom. So decrease glucose uptake, increase glucose reabsorption, that's all. But if you take the diffranzo's ominous octet, he always tell the drug should be in such a way it should address all the pathogenic aspect of type 2 diabetes. So this is where you can see GLP-1RS. I'm sure after seeing this, all of you will raise hand. So GLP-1RA work on 6 out of 8 pathophysiological pathway of type 2 diabetes. So see the mechanism of action when it compared to other drugs as well. GLP-1RA definitely scores over SGLT2 inhibitors, DPP4 inhibitors, sulfonylureas, any drug. You compare GLP-1RA scores over. You can see in this slide. So to prevent complication, ladies and gentlemen, it's always the tackling the root is important. See, hyperglycemia is the root cause to prevent all these things. We all know 1% decrease in HbA1c decreases 21% diabetes-related death, 14% myocardial infarction, 37% microvascular complications, 43% amputations and death. So you can see this slide, the changes in the HbA1c, how the GLP-1RA scores over the other things. Like if you can see the SGLT2 inhibitors, it's only 0.8. Here you can expect up to 1.5 reduction in HbA1c. That is the advantage of GLP-1RA. So 5 to 10% loss. The current bench of success first proposed by Sign Guideline way back in 1996, we all know it always reduces the various complications associated with type 2 diabetes. So diabetes is a war. Just like a war, soldiers use effective weapons at the start. We doctors need to use our most effective agents to protect our patients from the reach of complication. So you can see the body weight change relative to placebo. Once again, you can see this GLP-1RA scores over the SGLT2 inhibitors. So coming to an important aspect, that is the contemporary CVOTs. See, there are so many CVOTs with regards to GLP-1RA. So 2, 4, 6, 8. But when it comes to SGLT2 inhibitors, it hardly 6. So once again, GLP-1RA scores over SGLT2 inhibitors with a very positive outcomes. So you can see in this slide, when it is compared between GLP-1RA and SGLT2 inhibitor CVOT, looking at the bunch of evidence on the right hand side, you can see GLP-1RA CVOT is 56,000 patients, mean reduction is 12%, SGLT2 inhibitors 42,000, once again less patients, mean risk reduction is 10%. So important thing to be noted here is the favorable results in terms of number to treat for GLP-1RA is 1:75, but when it comes to SGLT2 inhibitors is 1:97. So anti-inflammatory, anti-atherosclerotic disease modification you can see with GLP-1RA. There are so many benefits with GLP-1RA. It increases the cardiac output, increases the myocardial contractility, whatnot. All the benefit aspects to improve the heart functions is there with GLP-1RA. So you can see in this slide the recommendations from ADA. After the two major study with liraglutide and semaglutide, they have changed the recommendation as the first line add-on after metformin. So cardiovascular betterment continuing in 2019 and 20 respectively, the oral semaglutide was approved by the FDA and EMA for the treatment of type 2 diabetes to improve glycemic control. In both labels, data from Pioneer 6 included confirm the CV safety of oral semaglutide. So ladies and gentlemen, GLP-1RA is not just an agent enrouting the cause effectively, it's beyond that. So incidence of stroke, globally, stroke is the second leading cause of death. In 2019, the incident cases of stroke was 12.2 million, prevalent cases of stroke was 101 million, deaths due to stroke was 143 million, deaths from stroke was 6.55 million. So once again, you can see here the GLP-1 RA does better with stroke when it comes to SGLT2 inhibitors. So important thing is GLP-1 RA can be used at any level of EGFR. You can see in the bottom line. So GLP-1 RA is preferred even if the EGFR is 15 to 29. So once again, this one study shows GLP-1 RA helps in reducing the insulin resistance as well. Important aspect. Most important point to be another important point is here glucagon. So GLP-1 RA increases the insulin secretion, decreases the glucose secretion, whereas SGLT2 inhibitors decreases the insulin secretion and increases the glucagon secretion. So suppressing glucagon action should effectively decrease the long-term complications and metabolic derangements in diabetes, enhancing the quality of life of diabetic individual. Another highlight is future is good with GLP-1 RA. It's being explored in other areas as well, in Parkinson's disease, Alzheimer's, NASH and PCOS as well. If you see the SGLT2 inhibitors, Dr. Praveen has shown the various complications and risk associated with SGLT2 inhibitors. So see the recommendation what they have seen. Way back in 2016, the FDA added a warning for increased risk of leg and foot amputations with CANA. In 2018, 4 years gangrene. So various complications are seen which can be very detrimental to patient on SGLT2 inhibitors. That is where the GLP-1 RA scores over. So if you see the side effect thing, you can see the various aspects. The complications with amputations, hypotension, ketoacidosis, kidney injuries, fornix gangrenes, mycotic infection, bone cancers, bladder cancer, bone fractures. So many things are there with SGLT2 inhibitor. Do you want to, when you weigh between GLP-1 RA and SGLT2 inhibitors, seeing at this, definitely GLP-1 RA scores over the SGLT2 inhibitors. My opponent will be ready with the cost. I'm sure she will be ready with this cost factor. But see this slide, preventing a cardiac event, you are going to save nearly 2.5 lakhs. And most important is patient life. So at this point of time, you should not, I'm seeing the time here. So looking at this cost benefit, definitely in preventing a heart attack, the GLP-1 RA should be the preferred agent. Coming to the guidelines, you see in this guideline where GLP-1 RA is placed in all the top good things when it compared to SGLT2 inhibitors. The first name comes is GLP-1 RA. Next is the SGLT2 inhibitors. So it is well placed in treatment guidelines. Once again, another slide shows from the ADA, the GLP-1 RA is top placed. So this is an international treatment recommendation. Very simple but very interesting slide. You can see from the top, the metformin plus or minus OADs, patient at lower risk. See the main things. The recommended drug is GLP-1 RA. Weight KSU, recommended drug is the GLP-1 RA. When there is a CV risk, once again the GLP-1 RA scores over the SGLT2 inhibitors. To summarize my talk, to tackle the diabetes related complication, the need is to enroute the cause, hyperglycemia, obesity effectively. GLP-1 RA from many clinical trial has proven itself as a powerful agent targeting the core underlying causes. Its potential in reducing MACE and stroke is noticeable. How can we forget how GLP-1 improve the metabolic derangements? How to play this? No, not this one. Play. You have to play this. Video is that? Where? Yeah, okay. How do you play? Yeah, yeah. Powerful people come from powerful places. Hey, what? Powerful people come from powerful places and make the place more powerful. You know this famous dialogue, isn't it? GLP-1RA in Diabetes India, powerful drug comes with powerful data and makes the treatment more powerful. I hope you all agree on this. Not but that the least, see this Diabetes India conference is there. You just observe his face. See the GLP-1RA. GLP-1RA definitely stands taller than the SGLT2 inhibitors. Oh. Over to you now. Over to you.
Thank you. I request Dr. Purvi to take up the challenge. This has really been a celebrity debate, including involving celebrity molecules. So I would like to briefly introduce Dr. Purvi. She doesn't need any introduction. She is the consultant diabetologist and director of clinical research at Lina Diabetes Care, Mumbai, and Diabetes Research Center, honorary consultant diabetologist at Bharati Ayurveda Hospital and Mahavir Hospital, Mumbai. She has been co- and sub-investigator at various centers. She has been the organizing secretary of various meetings, including women and diabetes conferences. And she is an RSSBI social media core team member, joint secretary of Central Coast Medical Association. She has got a lot of awards and presented a lot of papers. And I request Dr. Puri to continue with the debate.
So at the outset, let me say a big thank you first of all to Dr. Banshi sir, Dr. Arvind sir who's sitting here, and Dr. Jyotidev sir and everybody from the team. It wasn't my idea to debate against a friend, but we are just debating and not arguing. So yes, first of all, I want to say again that we should get this team of scientists who made the oral GLP-1 to work on the insulin molecule, because they were so desperate that in a matter of 20 years they just managed to make an oral pill out of something, out of a peptide. Let's get them on the insulin project as well. And the second thing I want to say is I'm also very thankful to the US FDA for being so alert and making us all aware of the different side effects that we have actually noted with these newer classes of drugs that have come up, because without this kind of pharmacovigilance, we would not be good physicians or scientists or doctors and not doing our justice in the clinic. So with that, yes, Diabetes India, and everybody wants to know what it's going to be. And the crux of diabetes management, even though diabetes is a cardiovascular disease, as we know, is essentially targeting, we can still change the destiny of somebody with diabetes if we can control all the major cardiovascular and renal, all the risk factors. If we can control them, then we can still change the destiny of somebody with diabetes. Well, older age, prior heart failure, cardiovascular events, peripheral artery disease, kidney complications are a subgroup of patients that are most likely to die because of diabetes worsening the other conditions. And obesity, one cannot really exclude that. It's one of the biggest cardiovascular risk factor, as you know, and the end is not very happening. It's all about cardiovascular events, occurrence, coronary artery disease, heart failure, arrhythmias, and sudden death. So we know the importance of that. And then again, type 2 diabetes, even with all the multidisciplinary approaches and all the chronic care model and this model and that model and everything, we know today that it is not just a glucocentric approach, but it is a multi-risk strategy, and cardiorenal protection is a very, very fundamental aspect of it. So with that, I introduce, or I quote Dr. A.K. Singh again. I quote him here to say that SGLT2 inhibitors are novel, potent, oral, inexpensive drugs for us that decrease blood glucose concentrations by reducing glucose reabsorption from the proximal convoluted tubules and by increasing urinary glucose excretion. And as Dr. Arvinda showed in his circular diagram, we just have to flip that around and SGLT2 inhibitors are right up there. It's a circle after all. The earth moves around and we see the sun rising every single day and set as well. So durable glycemic efficacy, body weight, blood pressure reduction with cardiovascular benefits, as well as renoprotective actions without higher risk of hypoglycemia, leave alone the weight gain part of it that insulin might have offered. We have something that's highly, highly recommended. And again, there is evidence of reduction in beta cell stress and hyperinsulinemia as well. So of course there are problems there are problems like any other drug class that we can think of, including even a paracetamol. But again, adequate counseling, alertness and watchful vigilance can always help us prevent them from aggravating further. So overall, if I have to just quickly say that metabolic benefits starts with reduction in HbA1c, and we've seen both SGLT2 inhibitors and GLP-1 receptor agonists. Body weight reduction is there. Blood pressure reduction is almost universally seen with SGLT2 inhibitors. And again, no hypoglycemia risk with both of them. But in particular, I want to talk about body weight to you. Even as monotherapy, using both, there is a beautiful dose response that you can see, both with the lower as well as higher dose response, with the lower as well as higher doses of SGLT2 inhibitors, and up to 2.5 kilograms, and that is surpassed only by the probably the oral GLP-1 receptor agonist semaglutide. And that's not it. Even as dual combination therapy, we can see, but the most impressive one is in the background of metformin and pioglitazone, we can still see that canagliflozin 300 milligrams caused a 3.7 kilo reduction, and I think that's very, very impressive. Again, there is evidence to say that the epicardial adipose tissue, which is the nidus of inflammation that causes atherogenesis as well as the root cause of myocardial infarction, is also contained by SGLT2 inhibitors, which is very, very impressive. And again, if we compare them with most GLP-1 receptor agonists, I think they are more or less, I won't be unfair to them. They are definitely better against most, but maybe semaglutide would cross that. Now coming to cardiovascular disease, we know that the 3-point MACE is seen, the risk reduction in the CV outcomes in patients with type 2 diabetes and cardiovascular disease or high cardiovascular risk. SGLT2 inhibitors and GLP-1 receptor agonists both show favorable effects on the long-term cardiovascular outcomes, but here comes the hospitalization for heart failure, and we clearly know that SGLT2 inhibitors score much better here because GLP-1 receptor agonists are neutral. Well, in the cost analysis that Dr. Arvinda showed, there was no mention of heart failure, and today we know that heart failure exists in, even asymptomatically in so many patients. Again, in this meta-analysis of randomized controlled trials in patients with type 2 diabetes and cardiovascular disease or high risk, high CV risk, SGLT2 inhibitors showed a consistent beneficial effect on hospitalization for heart failure not observed with GLP-1 receptor agonists. Again, the real world evidence also showed that there is a consistent reduction in the same with SGLT2 inhibitors inhibitors in patients with type 2 diabetes, regardless of the cardiovascular disease status. In the sense, even with no prior history, we would still see a reduction. Now coming to kidney disease, well, again, hard kidney outcomes like doubling of serum creatinine or progressing to end-stage kidney disease. Albuminuria is sort of reduced by both, but these are the hard kidney outcomes that are clearly favored. There is a relative risk reduction with SGLT2 inhibitors as compared to GLP-1 receptor agonists. And again, the relative risk on worsening EGFR, end-stage kidney disease, or renal death, we have seen that SGLT2 inhibitors significantly reduced that by, the relative risk reduction was 45%, while GLP-1 receptor agonists did not. Slowing of EGFR decline, we don't want kidney disease to progress, right? Why bother about treating it when you can prevent it? So again, we've seen there's a consistent improvement with SGLT2 inhibitors, and which is not consistently seen across GLP-1 receptor agonists. Well, again, after excluding for macroalbuminuria, because that is something that drives kidney endpoints for GLP-1 receptor agonists, but when we remove that factor, SGLT2 inhibitors still stand out and show a consistent benefit versus GLP-1 receptor agonists. And that is why they are today the favorites of not only cardiologists, but also nephrologists, physicians, diabetologists, and endocrinologists. SGLT2 receptor agonists, as seen in this network meta-analysis, were very consistent in reduction of risk ratio for MACE in patients with CKD, but GLP-1 receptor agonists were not. And again, we can see that for renal outcomes in CKD patients, again, SGLT2 inhibitors in this particular network meta-analysis were more beneficial than GLP-1 receptor agonists. So overall, even the real-world data seems to be favoring SGLT2 inhibitors. Even in terms of other conditions like hyperuricemia and NASH, we have seen benefits, clinically significant benefits with SGLT2 inhibitors as compared to GLP-1 receptor agonists. And the ethnic response, be Indian, buy Indian, and try things that are better for you. So in terms of ethnic responses, again, Dr. Mohan and et al. Have actually shown us that SGLT2 inhibitors have a significantly higher response in Asians as compared to DPP-4 inhibitors. Well, we don't know about that with GLP-1 receptor agonists. And pharmacoeconomics, again, this particular, and there are several analyses, but I think this one really showed that, well, there was better adherence because a drug is as good as it is used. And better adherence, less discontinuation, and lower cost with SGLT2 inhibitor, canagliflozin, as compared to a GLP-1 receptor agonist in type 2 diabetes. I have a minute more. So I've even compared oral semaglutide and canagliflozin at 300 milligrams. Both are oral drugs. And again, I think you can see the table for yourself that, besides all the similar benefits that they have, there's really a lot of convenience and a lot of plus benefits that we can see with SGLT2 inhibitors as compared to the GLP-1 receptor agonists. Again, this is something that I've just walked you through. But the specific factors also we have talked about, and we know that whatever said and done, heart failure is not favored or not benefited by the use of GLP-1 receptor agonists. So 2021 was clear that all the guidances were very clear in saying that okay, first line therapy is metformin, but look at the risk factors or established disease. But 2022 has gone, probably a step further to say that first-line therapy should, include all these factors or considerations of comorbidities, patient-related factors, cost and access as well, besides generally including metformin and lifestyle changes. So I think this is also a very, very important line in our consideration of access and other things. So again, I think Dr. Piyush Desai also went through this, and SGLT2 inhibitors are definitely preferred by the KDIGO guidelines as well in type 2 diabetes and CKD. Again, the statement by the European Society of Cardiology on SGLT2 inhibitors say that in individuals with heart failure with reduced ejection fraction, with or without diabetes, risk of CV death or hospitalization for heart failure is reduced by dapagliflozin or empagliflozin. And similarly for CKD as well, they say that in individuals with proteinuric CKD with or without type 2 diabetes, the risk of kidney disease progression is reduced by dapagliflozin. So let's say that we are really progressing well, not only in the diabetes patients, but these have a myriad of benefits that go beyond diabetes. So again, the AHA guidelines say that in patients with type 2 diabetes, either established CVD or at high cardiovascular risk, SGLT2 inhibitors should be used to prevent hospitalizations for heart failure. And in patients with preserved ejection fraction, SGLT2 inhibitors can be beneficial in decreasing the hospitalization for heart failure and cardiovascular mortality with SGLT2 inhibitors. So they are definitely multitasking oral inexpensive anti-diabetic agents here to stay. HbA1c reduction and all the benefits that I talked about are all, and there is adequate guidance to use them in newly diagnosed patients, those with multiple risk factors, prior MI, ASCVD, CKD, heart failure, both reduced and preserved, potentially in type 1 diabetes, even pre-diabetes, we don't know. The risk-benefit ratio is the key. I'm just done. Adequate counseling for UTIs is not to be compromised on, and not to use in contraindicated patient subgroups. So with that, of course, I come from Bombay, and Bollywood is a big part of it, so I'm not going to just settle for RRR or KGF, what did you say? But I'm actually proposing that why not give the benefit of both the classes, which are novel, and you know, today we have an oral option also, even though frightfully expensive to our patients. So yes, Karan, Arjun, we can use them both in our patients. Again, there are several trials with that, and then maybe with a metformin as well in the middle. So with that, I thank you very much for your.
See, whenever there is an IPL match is going on, if the overs are not done on the right time, it will be punished. So we should punish Purita. She took an extra time. Man, see, that is the thing. Already she's trying to convince. It's not possible. Extra time is not possible. Chairperson, you should take a note of it. So another thing is, see, that is the reason. So when GLP-1 array is there, it has got a sufficient scientific data is there, cardiovascular benefit is there. Yeah, cost, yes, I showed you 2.5 lakhs can be saved. Most importantly, heart is saved of a patient. So we have a powerful drug with the powerful data that makes the diabetic treatment more powerful. GLP-1 array, झुकेगा नहीं.
जाओ क्लोज कर दो बराबर. अभी आया नहीं है, वो आएगा तुम्हारे पास. उसका क्लोज कर दो.
How many are for GLP-1 receptor agonists? And how many are there for SGLT2 inhibitors? I think Dr. Ajgaonkar has convinced more people. Yeah, I think we will move quickly forward to the next session. And for my surprise, again, it is a battle between Bengaluru and Mumbai.
सर का है, ले लो, सर का है.
And
डाल दो फ्रावर.
this is again another very fierce battle which is coming up. Certain areas have been unfortunately victimized. Yes or no? For yes, we have Dr. K. Manohar, who again needs an introduction. He is the consultant physician and neurologist at Sharda Medical Center at Manipal Hospital. And he was the organizing secretary of KRSSDI and chairman reception committee of EPICON 2018, and he's received multiple awards of excellence in diabetes care. And he's authored many textbook chapters of many papers and presented sessions at various conferences, regional and national level. Over to you, Dr. Mohan.
Thank you. I think KGF won there, but we'll promise that we'll dance for the banquet with some Bollywood numbers.
So before you start, how many of you with Manohar sir that
Sulfonylurea are victimized. How do you feel that sulfonylurea are being victimized?
And how many of you are against? So there are so many Karan Arjun now, not from the Karan, not from the Arjun. Okay, sir. Yeah.
So IPL traditionally Mumbai Indians has done well. As my chairperson said, that it's again a Mumbai Indians versus RCB now. But I think we'll need Mumbai Indians' help tonight at the match so that we can move up the ladder. Sulfonylurea are unfortunately victimized. They are wheel caught in the plot of newer molecules. Trials, we all know, we always design it to suit the molecule in contention and defame what is good that time. Again, I always talk about this debate, but somehow I get dragged into the debate, and luckily this is not against Arvind, which I have done many times. So this was question already asked by the chairperson. So motive one, see, there is always an inherent motive by people to defame these good old molecules. Huge market, everyone knows the most prescribed drugs as an individual or in combination with metformin, even to date, even after so much of victimization, is sulfonylurea. So most cost effective molecule, even though you slash rates of other things. It features in the essential list of medications for Southeast Asia. Well, you can debate it here, but useful in pregnancy, glibenclamide if someone is not willing to take anything else, cardiac, renal and hepatic dysfunction, dosage alteration, be smart, and you can still use it. It was like a neighbor's envy and owner's pride. So victimize it is what my friend will do. 65 years on and still going strong. This is the first molecule to be launched. Oral anti-diabetic agent just behind insulin. So defame it, grow your new market. Look at this prescription pattern. Fact one, you look at it, evolution of treatment preferences, even from 2011 to 2020, still it is the most prescribed thing. You may talk something in the hall, but what are you doing when you're sitting in front of your patient? You're still prescribing it. Fact two, worsening glycemic targets over the 2 decades. This is the data where we have seen that in spite of all those fancy molecules which are shown here, I don't know, I didn't get the pointer. So still the A1C changes or the percentage of people attaining the goal, whatever we want, is still almost the same. If they were so really good, why has it not changed dramatically? Unmet need, another 10 molecules come, they keep using this or abusing this, a hyped terminology just to fit in their bracket. It's like we have a drug now, let's find a disease, let's find a space to grow it. So that's what people have victimized sulfonylureas. Prescription pattern, that's what I was telling, walk the talk. Even today, with vildagliptin, metformin being cost effective, still the number one prescribed combinations across, when you take a survey, is still sulfonylurea metformin combination. And verdict one, before we jump onto it, I give one verdict. Already all the guidelines, let it be ADA or even our own RSSDI, IDF, WHO, they still say there is a huge scope for using sulfonylurea metformin as a combination. They still remain the mainstay of therapeutic efficacy, safety, pleiotropic benefit, low cost. Still they are the answer. Then why is it? You want to victimize, there is a group, pick up the weakest, worst, and highlight as if everyone are same. Glibenclamide is shown to be the sulfonylurea. Ischemic preconditioning, severe hypoglycemia, but we are not talking about the newer variants of sulfonylureas. Agent specificity is not as highlighted as it should be when they were comparing with molecules. They are a contemporary class. They are like Bhagavad Gita, Holy Bible, or the Quran. We all started and grown beyond that after that only, but never
victimize it. Of course, they may have some here and there benefits. Yes, we agree. But why do we victimize something which is done for so well for so long? I won't even dispute. I won't even go near this. Glucose efficacy unprovenly. It is still behind insulin. False allegations. What are the people are doing? Weight gain, hypoglycemia, often hyped, and beta cell exhaustion, and CV outcome trials. Actually, it was a blessing in disguise. Talk about the Carolina trial. They thought, of course, there is a great molecule, linagliptin, sulfonylurea causes all those 4 adverse effects. So pitch it against it, and you see they are not CV safe. Hypoglycemia is a big issue. No. What did it say? Not only Carolina said it was CV neutral, as good as linagliptin, but 6-year glucose control. We never had such a long-term data about sulfonylureas. It was the same. It also rested the beta cell exhaustion hypothesis. Not only about the CV outcome, but also beta cell exhaustion was hypothesis. I think, again, I will not go into this primary, secondary outcome. Everyone knows here, very learned audience. So meta-analysis, falling short of what I was talking about the Carolina trial. Even if you look at the meta-analysis, on top, this glibenclamide was the main culprit, actually. So, but they showed it so much that sulfonylurea are all similar, and most of the CV outcome or CV risk associated with glibenclamide was overhyped and highlighted as it belongs to everyone. So class effect and fooled us. And this is another funnel plot which included other agents like SGLT2 inhibitors and DPP4 inhibitors and other class of agents which didn't show any major pointers towards increased CV outcomes or CV hazards with respect to sulfonylureas. The second false allegation is beta cell exhaustion. Again, I will not get into it. This is another I like this trial called the GREAT trial, which was into 4 arms. As you can see, sulfonylurea, DPP4 and GLP-1 and insulin glargine. And it was a neutral trial by the NIH. And what did it say? The percentage of participants who developed A1C more than 7, it was as good or even better than what sitagliptin did. But of course, glargine and liraglutide did slightly better. But again, it reinforces the trust in sulfonylurea as a molecule. Again, the victimization concept is highlighted here. Durability, again, I said Carolina already showed that it is 6 years at least as good as durable as the linagliptin, which was a contention there. Hypoglycemia, often hyped, is what I will say. What is hypoglycemia? You start a clinical trial with a molecule which is the least risk of hypoglycemia. You keep on intention to treat to target, push it till someone suffers from a hypoglycemia and highlight it. This hypoglycemia was more with sulfonylurea. Of course, we know that. And nocturnal hypoglycemias are high. But put it in real practice. How many people really see as much as it is shown? We see definitely. A safe, smart approach to it, educating a bit, will undo this risk of hypoglycemia. And weight gain. This is another one. We all know weight gain is associated with sulfonylureas, can be an initial indicator of reduction of glucotoxicity. And what did the other trials, meta-analysis, looked at it at 5 years. There was no significant weight gain associated with sulfonylureas as it was hyped up. And even Carolina trial, again, get back to that, 0.8 milligram weight rise was seen with glimepiride, which plateaued. 0.8 is not much, of course. So it's a weight neutralizing effect. It is also seen in this systematic review of meta-analysis, which showed the maximum weight gain was 2.1 kilogram, and statistically it was not significant there. Legacy effect, come any drug, and this is one point of highlight of talking. Legacy effect, go early, hit strong. Where did you get the data from? UKPDS, what was the molecule used? Sulfonylureas and insulin. So cost, of course, people alluded to it. Of course, nowadays the other costs are coming down, but even otherwise, if you look at the cost adjustment, you can buy statin, aspirin, or ACE inhibitor for your patients. So friends, traditional bashing points of sulfonylurea. Durability, Carolina GREAT trial, I've answered it. Hypoglycemia, yes, it is a problem, but use it smartly and it won't be much of a problem. CV outcome, this was designed for bacha molecules which came much after sulfonylurea, not before that. But there also Carolina answered it. Weight gain, yes, it is modest but not very, very significant. And my good friend will come and speak on it, and I would like him to have an independent CID investigation into how sulfonylurea was victimized, and he will agree with me. Hostile witness or approvers. These two trials are the approvers for sulfonylurea as a molecule. Carolina and Guide, they thought they can victimize and get away. No, they gave good scientific data for sulfonylurea. Glucoconfidence, glucosafety, and gluconomics. So friends, you try to victimize us, you know sulfonylurea chukega nahi. And we know what happened to the other Bollywood badshahs, what they're doing now. So I would call upon our close friend Shah to take over next. And one size does not fit all. In debate, I always believe we never lose. We either win or we learn. And for sulfonylurea, friends, you are not a victim. Sulfonylureas are the victors.
Now I would like to introduce Dr. Tejas Shah. He is a diabetologist and diabetes care center. Dr. Tejas Shah is a diabetologist and director at IVA Diabetes Center, Mumbai. He is honorary diabetologist at SL Reja Hospital, Diabetes Care Center at Malad and Andhari. He is visiting teaching faculty for fellowship diabetology at Dr. D.Y. Patil Medical College in Mumbai. He is also founder and president of United Diabetes Forum, organizer, scientific committee and faculty of CID 2014, 15, 16, 17, 18, 19 and 21. He is speaker at various national conferences like CID, RSSDI, IdeaCon, Diabetes India, Diacon, IdeaCon, and he is practicing diabetologist for past 23 years. Over to you, sir.
Thank you very much. First of all, a big thank you to the entire organizing team of Diabetes India and for the wonderful show. A special thanks to my dear friend Manohar for taking me back in time. My colleagues of my PG days, Rajiv, Manoj, all are here, and it just brought back memories as if I'm in the 1990s and we had only the sulfonylureas and metformin that we were talking about that time. And somehow I went back in that era. But anyways, sulfonylureas have been unfortunately victimized is what I have to say. That I agree that I say that there is a problem, and there is a problem which I'm going to highlight in the next 10 minutes. It's a simple questions have simple answers, I always believe. What do you expect from a telephone? A simple question asked maybe 20 years back, and the answer would have been it should help me to talk and it should help me to hear. But today if I ask a small kid also, what do you expect from a phone? And the list is endless. You need to talk, you need to hear, you need to chat, you need to see movies, you need to hear music, and the list is of course endless. So a simple question was asked to my dear Bansi Sabu. I have a very rare video footage of Bansi Sabu taken in 1997, where he was asked the same thing, that what do you expect from an ideal OHA? And this is what he had to say. So he had to say is that it's basically the tight glycemic control is what he is expecting from a oral drug at a given point of time. Though Bansi Sabu has not changed for last 25 years, he still looks the same. But many things have changed in the last 20 years, as we know. It's the way we watch movies, we see how we listen to music, how everything has changed, how we talk on phone. And so in the same way, something has changed is the way we manage our patients with type 2 diabetes. From talking about two initial drugs, only sulfonylurea and metformin initially, we have come a long way, and that is what we are going to discuss today. We are not here to discuss whether sulfonylureas are good or bad or their efficacy is bad. We all know, we are all using it for the last 40 years, 50 years. And we are not debating its efficacy. We are here to talk that why they have been pushed down the line, why the position of sulfonylurea is there down below, why is it a cost on, it's an option where only cost is considered, and that is what we are going to talk about. So in the last few years, we know that data has shown that uncontrolled diabetes can lead to complications and it can lead to reducing the burden of life. But there is no trial to prove the vice versa, that if we improve the control, we prolong life. Trials like UKPD, advanced VADT, all done with sulfonylureas. Remember that. They've all failed to prove a cardiovascular benefit. There has not been a single trial which showed that the cardiovascular benefit is there if you use a drug like sulfonylurea. And so the future is basically to add an event-free life rather than just to bring the sugars down. Cardiovascular disease has been the leading cause of death. We know that 50% of deaths in people with type 2 diabetes are related to cardiovascular diseases. What we also know that 1 in 3 people basically with type 2 diabetes have established cardiovascular disease, but the fact is only 2 out of 10 people actually get a drug which is meant to reduce the cardiovascular disease, or which will help in controlling the sugars as well as in reducing the cardiovascular diseases. Things were different in the era that Manohar spoke about. Things were different in the 1990s, where people were only targeting HbA1c, and it was believed that if you bring down the HbA1c, the complications will reduce. But following that, over a period of time, that was a time when drugs were approved only on the basis of HbA1c. But in 2008, rosiglitazone problem was there. FDA woke up and started introducing cardiovascular safety trials. And following that, it has been believed that we need drugs which will not only reduce blood sugars, but are giving benefits in cardiovascular diseases. So overall, we move from a glucocentric approach to a vascular glucocentric approach. So the question comes again is, can sulfonylureas reduce CV events or a 3-point MACE? Do they reduce heart failure or heart failure hospitalization? Can they give us the renal benefits with over and above the glycemic control benefits that they are giving? And can they reduce the CV deaths? Manohar showed us the last picture of Pushpa versus the Indian actors. That is what again I am coming to. Are we satisfied with 200 crores, and now we are aiming for 1,000 crores? So that is where we are talking about, that we want something more than what we are talking about, and we want something more benefits from a drug. So the answer is no. Despite 60 years of rich experience with sulfonylureas, there has been still no evidence, and nor Advance nor Carolina, nothing has proved that they give benefit. When it comes to pathophysiologic defects, we know that it's now working on a single pathophysiologic defect does not help. A patient with type 2 diabetes from the very beginning needs to be targeted at multiple defects, and therefore using a single drug where we are talking only about insulin secretion is not going to help, and therefore drugs which will work on multiple pathogenic benefits are the need of the hour. Sulfonylureas are the most powerful anti-hyperglycemic agents. Yes, we all agree. All diabetologists cannot do without a sulfonylurea when it comes to a patient with a higher HbA1c. But the fact again is that, are we looking only at the numbers of HbA1c? Are we looking at a drug which will reduce the blood sugar, but apart from that give us better outcomes? If you look at trials like EMPA-REG or DECLARE or any other trial, the difference in HbA1c between the placebo arm and the control arm or the drug arm was negligible. Both arms had a similar HbA1c reduction, but the outcomes benefits that were given were much superior in all these arms as compared to the sulfonylureas. So will the glucocentric approach work, or do we have to look beyond the power to reduce A1C? Let us look at some of the data that we have. Game-changing clinical trials have come up in the last 10 years. 3-point MACE reduction with LEADER. If you see LEADER, SUSTAIN 6 and EMPA-REG, all have given these benefits. Heart failure hospitalization primarily with all SGLT2 inhibitors. Renal benefits. When we talk about a patient with renal disease, we are always worried about hypoglycemia when we are using a sulfonylurea. But if we have a drugs which are giving benefits as well as stopping the progression of renal disease, why are we waiting for? If you look at the results from LEADER trial with liraglutide, again a 13% reduction in primary outcome, 22% reduction in CV death, reduction in non-fatal myocardial infarction also. SUSTAIN 6 as well as PIONEER 6 showing with semaglutide and oral semaglutide, showing that non-inferiority as well as superiority. EMPA-REG trial again with patients with established cardiovascular disease, showing a relative 38% risk reduction in terms of heart failure hospitalization and 32% reduction in overall CV death. When we talk about dedicated CKD trials, all patients with established kidney disease with GFR between 30 to 60 or 30 to 90 were there in these trials, and all showed a progression.
Less than 2 minutes.
Okay. All showed a problem in progression of diseases. Yes, modern SUs are CV neutral, but again, are we satisfied with neutrality or do we want superiority? If you look at advanced UKPDS, all these trials had sulfonylurea as the baseline drug. What did UKPDS show? Yes, it showed a benefit of macrovascular disease, but when you dissect UKPD, if you look at the arm where sulfonylurea and metformin both were used, there was an increase of cardiovascular disease or mortality seen as compared to the metformin arm. So the Carolina trial, we are very happy with neutrality, but it showed a problem with increased risk of hypoglycemia and weight gain. So friends, yes, we agree that we need to do something more for sulfonylurea beyond sulfonylureas. So Manohar, definitely I think you should plan to quit ahead, or should I go ahead? Then the question comes of apoptosis. We have been talking about apoptosis with sulfonylureas for a number of years. Any drug which causes increased insulin secretion can lead to beta cell exhaustion. Hypoglycemia is not a small factor or not a small thing to talk about. It has a problem and it is a major cause of cardiovascular disease. Meta-analysis have shown increased risk of hypoglycemia with all sulfonylureas. And that is why now we are talking about in 2022, where the problem is that sulfonylureas are right here only when cost is a concern. So friends, cost is not a concern anymore when we have a drug like a Vilda or a dapagliflozin available at a cost of sulfonylureas. Why are we even talking about cost here? So they are the cost compromise options now in today's times, and they have not been unfortunately victimized. There is a scientific evidence behind this. There is no CV protection, there is short glycemic durability, there is increased beta cell apoptosis, there is weight gain, there is increased risk of hypoglycemia, and of course cost is not we are going to worry about. Last not the least, there is something more. Today again I encountered our dear friend Dr. Bansi Sabu after 25 years, and this is what again he had to say. So, as I told you, don't concentrate on how he looks. He looks same for the last 25 years. I told you all in the very beginning, just listen to what he has to say. Thank you.
I think
that was black and white era, this is a colored era. That's what he had to say, that we are now in an era where we are looking beyond glycemic control and we are looking at mainly drugs which can improve the outcomes and which will reduce the complications. Thank you.
Dr. Manohar for your rebuttal.
I have a very big point to make here. See, what is the topic? Topic is victimizing sulfonylurea. I never said sulfonylurea is better than the newer drugs. No. So that is the whole direction in which the debate went was wrong is what I felt. What I meant is, we know there is hypoglycemia, we know there is weight gain, we know there could be a beta cell exhaustion. We overdid it. We showed to the world it's a crime to put sulfonylurea. But Carolina and Guide trial said no, that is not the case. Secondly, technical point, he told about CVOT trial, their A1C was similar. It has to be similar. At the end of the study, 0.4 or more, if the A1C difference is there, then the glycemic benefit will outweigh this thing. So what I'm trying to tell friends, I'm sure all of you would agree with you, is sulfonylurea lambi race ka goda hai. It's a marathoner like. Thank you.
At the end of the discussion, we will have the final vote. So,